Kanna sir, good evening, sir. Srinivasan sir, good evening, sir. Jailal sir, good evening, sir.
Good evening, sir.
Good evening, sir. Jailal, sir.
Good evening.
Kanna sir, good evening, sir.
Kanna, sir. Good evening, sir. Srinivasan, sir. Good evening, sir.
Srinivasan sir, good evening, sir.
Pradeep.
Kanna sir, good evening, sir. Think it is.
Good evening, sir. Kanna, sir.
ஜெயராம் சார் நமஸ்காரம்.
Jailal sir, good evening, sir.
இப்ப எங்க இருந்து எந்த ஊர்ல இருந்து பேசுறீங்க சார்?
Kanyakumari.
என்ன சார்?
இப்பதான் இன்னொரு பிரஸ் மீட் முடிஞ்சு அதனால அப்படியே
நீங்க வர முடியல நெக்ஸ்ட் டே.
Dolo 650 issue is now going around. No, there is
ஆமா சார்.
lot of discussions on that.
Hi, Dr. Pradeep.
கண்ணா சார் நமஸ்காரம்.
Namaskar.
Sir,
Namaskar.
Pradeep sir, you are still in mute mode, sir. We are unable to hear you.
Is it okay, sir, now?
Yes,
Perfect,
sir.
sir. Perfect, perfect.
Yeah, Dr. Pradeep, seeing you after a long time.
Yes, sir. Actually, I am now on the verge of retirement.
Okay.
So just keeping busy with all other formalities. Meanwhile, actually, our Chief Secretary has issued an order that those who do not file property return annually are going to be charge sheeted.
Okay.
So this has created a sort of havoc ho gaya isme, sir. So that kept us busy. It's a online portal. The Haryana government has created an online portal to give all informations about yourself, your service record and everything. So hard copies of service book is not maintained now.
Okay.
So you have to upload these property return and everything on website. That is a very tedious job in the sense that it takes almost 1 day for 1 year. Now you can imagine how many years you have to, how many
But
days you have
probably
to.
the fresher to join with will find the system very easy, no, sir. But for people like you, very
Once you
senior,
learn, then it's easy. Yes. That's the problem actually.
sir, can we start, sir?
Yeah, why not? Why not?
Sir. Good evening, friends. Happy to host. In fact, today we are covering the 300th case discussion for the entire PG clinics, which has happened over the last 2 years. And we are happy to host all of you this evening. Professor Modi is going to join in another 30 minutes or so. He had some emergency. He joined and he had to leave. Pradeep sir is already here. Kanna sir, Jailal sir, Srinivasan sir, Sakai sir, Karunakaran sir, and all senior faculty here. We warmly welcome. We have two important cases here. One is kindly contributed by Professor Jailal sir himself, a case of testicular tumor. The other case is from Coimbatore Medical College under the leadership of Srinivasan sir for case of thyroid. Naveen, are you with us?
Unmute yourself, Naveen.
Sir, yes, sir.
Naveen, please, good evening. Warm welcome to you.
Sir, good evening,
please start your PowerPoint.
sir.
Please introduce your unit chief, head of the department, and start your presentation. Good luck to you.
Yes. Yes, sir. Thank you, sir.
I think Modi sir is also joined already. 1 second, ma. Modi sir, good evening, sir. Pankaj Modi sir.
Is connecting to his audio.
Yes, sir. Yes, sir.
Pankaj sir, good evening.
Sir, you are in mute mode, sir.
Mute.
Naveen, no camera konjam adjust பண்ணுங்க. Dress எல்லாம் தெரியாம.
Pankaj sir, come little bit front. Good evening.
Good evening.
Always at the forefront, sir.
He finished his long tour. He was having some long tour outside, sir.
Pankaj, we are not able to see. Sorry, Naveen, we are unable to see your PPT.
They ask that all PG should join. Okay.
Yes. Make it full screen, ma. Okay. Good luck to you, ma. Switch on your video.
Okay. Okay.
Sir, shall I start, sir?
Please, ma. Good luck to you.
Yes, sir. Thank you, sir. Sir, good evening, esteemed faculties. I'm Dr. Naveen, final year postgraduate from
Your video is
Kanyakumari
not
Government.
seen, ba. You put on your video. Your face, people should.
Sir, yes, sir.
No, your
Naveen.
video is not there.
Sir,
PPT ல போடு நவீன்.
Okay.
Full screen வர மாட்டேங்குது. இன்னும் பெருசு பண்ணலாம். That's good. That's good.
yes, sir.
Sir, Sanama, switch on the video so the examiners can see you.
Yes, sir.
You start presenting, sir.
Sir, sir, I'll on my video, sir. Once again, sir.
Go ahead, pa. Go ahead. Don't waste time.
Naveen, you please start your presentation, Naveen.
Sir, now am I visible, sir?
Sorry, ma.
Sir, now am I visible, sir?
We are not able to see you, ma.
I think I am able to see him. He is seen. Yes.
Sir.
Okay.
Yes, sir.
Yes,
Okay,
you are
good luck.
seen.
Now
luck.
you are okay. Please start your PPT.
Okay, start it.
Yes, sir. Yes, sir. Sir, I am Dr. Naveen, final year Kanyakumari postgraduate. Sir, my HOD is Professor Dr. Jailal, sir. And my unit chief is Professor Dr. Angel Vincent, sir. And my unit assistants are Dr. Arun Kumar, sir, and Al Kumar, sir.
You are using two
Another
devices.
audio you are connected. That is, you close that second one.
You people are better in this. Can to do it early and keep it ready so that I think one you are speaking from the phone, one you are
Yes, sir.
speaking in the, yeah, one audio is enough.
Sir, yes, sir. Other one I muted, sir. Sir, I'm starting my case presentation, sir.
Please, please.
Sir, a 40-year-old gentleman who's a resident of Nagarkoil came with chief complaints of swelling in the right side of the scrotum for the past 6 months, sir. The patient had noticed a swelling in the right side of the scrotum 6 months ago, which was insidious in onset and gradually progressing in size over the 6 months, sir. It is not associated with any rapid increase of size. It is associated with the sensation of heaviness over the right side of the scrotum, sir. Patient gives no history of trauma, no history of pain, no history of fever, and no history of swelling in the opposite side of the hemiscrotum. There's no history of any other swelling in the groin. It's not associated with loss of weight or loss of appetite, sir. No history of cough, hemoptysis, or dyspnea, sir. No history of jaundice or abdominal distension, and no history of back pain, sir. Moving on to the past history, sir. He's not a known case of diabetes, hypertension, bronchial asthma, epilepsy, or CAD, sir. He has no past surgical history, sir, and no history of undescended testis in the childhood, sir. His personal history, he takes mixed diet, sir. The bowel and bladder habits are normal. He's not a smoker and not an alcoholic, sir. The summary, a 40-year-old gentleman came with chief complaints of painless swelling in the right hemiscrotum for the past 6 months, which is insidious in onset and gradually progressing with no other positive history, sir.
Go to your first slide, then the last slide.
Yes, sir. Yes, sir.
Yes, sir. Pradeep sir, Modi sir, take. Ajay sir, good evening.
Good evening, sir. Actually, you said that it was a painless swelling.
Yes, sir.
Not even dragging sensation was there.
No, sir. He just complains heaviness. sir.
Actually, we have seen the slide presentation, entire one.
sir.
In the examination, it is associated with sensation of heaviness. What is heaviness actually? Sensation
sir.
of heaviness.
Sir,
How is
not
it?
dragging, sir.
Pardon me?
Sir, sir, he's aware of something in the scrotum, sir.
Normally, you don't have any sensation of carrying any testis in the scrotum. But once it enlarges,
Yes.
You have already mentioned that it is associated with sensation of heaviness.
Yes, sir.
So what does it mean actually? That he feels that there is something inside the scrotum. Isn't so?
Yes, sir.
And this is not associated with any dragging or anything.
Sir?
Dragging sensation.
No, sir. No dragging sensation, sir.
Okay.
Okay. So which is a actually common condition you will find in scrotum, which causes enlargement in this region? Commonest.
Sir, commonest, sir, if the swelling is a testicular swelling, that is if it is not a scrotal wall swelling.
Navin, I am asking you swelling in a scrotum.
Yes, sir. Filariasis, sir.
Filariasis is not a common condition.
Higher,
We'll find
hydrocele, sir.
hydrocele, right?
Yes,
So
sir.
have you asked history regarding hydrocele? Because in history, you will not know whether it is a testicular swelling or a scrotal swelling.
Yes, sir.
So what are the things you will ask that it may be hydrocele? Though in that area, it is not common, but still. So what is the common presentation if it is hydrocele?
Swelling, sir.
Swelling, what else? The duration. So what will be the duration in hydrocele?
Sir, long-standing, sir.
In years. In
Yes, sir.
years. Most of the time it is in years. This
Yes,
is in month. Okay.
sir.
Have you asked any abdominal complaint?
Sir, abdomen
Go to the
distension
second
and
slide.
jaundice.
Go to the second slide.
Yes, sir.
So why do you have asked jaundice, distension?
Sir, in case if it is not a benign swelling or if it is a malignant swelling, a testicular tumor can spread to the para-aortic lymph node, sir.
So will it cause jaundice?
Sir, mostly testicular tumors spread by lymphatic spread, sir. In case of hematogenous spread,
I am asking you, will para-aortic lymph node cause jaundice or what will be
No,
the
sir.
presentation?
para-aortic node, there will be fullness, sir. Fullness in the epigastric region or mass in the epigastric region.
Mass in the
Yes.
epigastrium. So can you
Yes,
ask
sir.
that history? You have asked history of abdominal distension. Why did you ask that history?
Sir, mass in the abdomen only.
Okay. Similarly, I would like to, how did you ask history of swelling in opposite hemiscrotum? What do you mean by that?
Sir, comparatively, both the
How
testes
did you
are.
ask that history? Why did you ask that history? What is logic behind asking history that no history of swelling in him? So which swelling disappears without surgery in scrotum?
Sir, undescended testis can disappear, sir. Vanishing testis.
No. Without surgery, it will not disappear. So what I want to ask you, are you thinking only of testicular tumor or other similar testicular condition which can happen? You have asked history of pain, you have asked history of fever. Why
Yes,
did
sir.
you ask those histories?
Sir, testicular swelling associated with pain, it can
What
be.
do you call that? What is diagnosis if patient is associated with pain, fever?
Acute pain, fever, it can be testicular torsion also, sir.
Testicular?
Setting.
Pardon?
Sir, testicular torsion, sir, acute presentation with fever, enlargement of testis.
Which is more common? Torsion is not common at this age.
Sir, epididymoarthritis, sir.
Yes, always think of common condition first.
Okay, sir.
Okay,
Right?
the second point, I'll interrupt here.
Yeah,
You have
please.
to keep all
Please,
the
sir.
time his age into consideration. A 40-year-old male is unlikely to have torsion. So
Yes,
that is
sir.
more important.
Yes,
That
sir.
should be more important.
Right.
Okay.
But remember, acute or acute on chronic epididymoorchitis is always a differential diagnosis when you are thinking of testicular tumor.
Yes.
And in that case, there can be a swelling in opposite scrotum which might have appeared in past and has disappeared. Because of that, treatment might have taken. So always keep that in mind, right?
Yes, sir. Yes, sir.
So that is, you have asked history. Why did you ask history of trauma?
Sir, trauma, sir, 6 months duration actually does not point out to a hematocyl, sir, but it can be a chronic hematocyl due to repeated minor trauma, sir.
Okay, I will ask you another way. Almost all patients of scrotal swelling will have a history of trauma. How will you explain it?
Sir, the incident of trauma, the swelling can predispose the trauma, sir, but patient will notice only after he has a trauma, sir.
Yes, so it is usually a pointer to notice. Almost all patients of hydrocele will have a history of trauma. Similarly, that patient will correlate. It has no significance as such.
Yes,
Remember that hardly any swelling in the scrotum develops due to trauma. Which swelling can develop due to trauma? In scrotum.
Hematocyl.
Hematocyl. So how does it develop? You must have read everything about testicular tumor. You know it, but I am asking you basic because this is important when we are talking of scrotal swelling. How does the hematocyl develop? So I will tell you, usually it is following the hydrocele. There is a long, it's a hydrocele contains fibrinogen. As soon as there is a trauma, even slightest blood going into sets in a process and patient will present with hematocyl, but it's a rare. So trauma is almost always incidental, right?
Yes.
Would you like to rule out the history of hernia, the possibility of hernia in this case or not from history?
Sir, the possibility of hernia can be there, sir. It can be a secondary hydrocele also, sir. Hernia with the hydrocele can also be there, sir.
No, we are not talking about hydrocele. Hydrocele part is fine. Hernia,
Okay,
I'm talking.
Sir, since it is a pure scrotal swelling, if it is a inguinal swelling, I will think of hernia, sir.
Very good. That's a reasonable argument, yes. On history, it appears to be pure scrotal swelling. But have you asked history of reduction in size? Have you written there anywhere?
No, sir, I haven't asked, sir.
So it is important. In epididymoorchitis, associated hernia, there can be history of reduction in swelling. That is the important history you should always ask. No reduction in history will help you to do. Please continue, sir. Please, sir.
That's all from my side.
Okay,
Naveen,
next
go ahead
slide.
with the examination.
Yes, sir.
And remember one thing,
Yes, sir.
Naveen, you are taken
sir.
a very elaborate history. Go back to summary. Just so this is a summary of history, right?
Yes, sir. Yes, sir.
So most of the time, this will be in exam will come as a short case.
Okay, sir.
Keep this in mind, right? So yes, you might have taken elaborate history, but your summary should be more solid. This part nobody is going to ask most of the time, right?
Okay, sir.
So in summary, add only positive point, which is the diagnosis, right?
Yes, sir.
So here it is important there is no history of fever or pain or no reduction in size of swelling, which becomes important part of your this because examiner will not ask all those previous history. This elaborate history is not very, but summary patient examiner may ask, and in that case, always include this important point. Please continue with examination.
Naveen, may I just ask a question? Does this person have any children?
Sir, he is married and he has 2 kids, sir.
Have you mentioned that?
Sir, I have not mentioned that, sir.
Why is it important to know whether he's got children or
not? Sir, in case if it turns out to be a testicular malignancy, the minimum investigation required is architectomy, sir. And before I proceed with architectomy, I have to do sperm banking, sir. And also,
that is one.
And
so it's important to know whether he's got children. Also, more important, does sterility have anything to do with testicular tumors?
Sir, yes, sir. In undescended testis, more chance of sterility. So bilateral undescended testis has more chance of sterility, and undescended testis associated with the increased risk of seminomatous tumor development, sir. So
okay. Any other reason? Suppose he's got a normal testis yet. Is sterile. So anything to, how do you associate this with testicular tumors?
Sir, Klinefelter's.
Okay, what else? Klinefelter is one. What else? You could have taken treatment. There are certain, they take some medicine, steroids. They can precipitate. They can lead to testicular. So Klinefelter is one, and androgen insensitivity syndrome. These are two things which can result in. Okay.
Yes, sir.
What is androgen insensitivity syndrome? Do you have an idea?
Sir, androgen insensitivity.
As the name suggests, they are dysgenetic gonads. They are dysgenetic gonads which are not sensitive to testosterone. Okay.
Yes, sir.
About the other testis scrotum, have you asked?
Yes, sir. No swelling in the other side of the testis and in the groin also.
Is he into recreational drugs?
No, sir. No issue of drug intake. Not a smoker. Not alcohol.
Which drug would you ask for in the case of testicular tumor? Any idea?
Sir, no, sir.
LSD. LSD is associated with. They have a high incidence of testicular tumors. Okay.
Yes, sir.
So, should we go on with investigation?
I think examination.
Right.
Examination.
Yes, sir. So, general examination after obtaining proper consent in the presence of a male chaperone, the patient is examined in a well-lit room with the patient exposed from the nipple to the mid-thigh level, sir. Patient is conscious, oriented, afebrile, moderately built and nourished, no pallor, no stress, no sinuses, no clubbing, no pededema, no general symptomatology, sir. His ECOG score is 0. His vitals BP 120 per 80 minute, pulse rate is 80 per minute, and his respiratory rate is 15 per minute, sir. Sir, moving on to the examination of the inguinal region, sir. On inspection, 7 x 5 cm swelling in the right hemiscrotum, which is oval in shape. The surface appears to be smooth. The skin over the swelling scrotal silk contains rugosity, sir. There is no.
Can you turn back to the previous slide? Yeah.
Yes, sir.
You know what the swelling is normal with rugosity. Okay. Go ahead. Yes, go ahead.
Sir, no ulcers are visible over the scrotum, sir. No scars are seen, sir. Left hemiscrotum appears normal, sir. No other visible swelling in the inguinal region, sir. So left testis is there and the right testis is enlarged, sir. Scrotal rugosities are also present, sir. Palpation, 7 x 5 cm ovoid, not warm, non-tender, well-defined, smooth, hard in consistency swelling, which is non-fluctuant, non-transilluminant. Skin over the surface is pinchable. I am able to get above the swelling. I have not tested for the testicular sensations. And the left testis epidermis is normal. And I am able to palpate both the cord structures. And looking for the palpation of lymph nodes, there are no palpable inguinal, abdominal, and left supraclavicular lymph nodes, sir. Other system examination, CVS S1 S2 is heard, RS bilateral normal vascular position, sir. For abdomen is soft and no organomegaly, sir. Distal rectal examination, the anal sphincter tone is normal, fecal staining plus, and I'm not able to palpate any mass, sir. And for rectal examination, sir.
That completes the examination.
Sir, yes, sir.
You said you did not examine for rectal the testicular sensation. Any
Yes,
reason for this?
Sir, actually, if I'm suspecting a testicular malignancy, testicular sensation, tumor seeding can happen through the venous and lymphatic channels.
Yeah,
so,
if you try to squeeze the testis, it can see the seedling can occur. Okay.
Yes,
cord, you have already said that they are normal on both sides.
Yes, sir.
So the cord is not thickened
Sir,
on the right, equal on both sides.
Sir, if the cord is.
Okay, Naveen, can you go back to inspection? Just a slide,
yes,
previous slide.
Yes, sir. Yes, sir.
Okay, how did you on inspection measure this approximately 7 by 5 centimeter?
Sir,
from your slide, I am unable to see any swelling as such.
Sir, make the patient in the standing position, sir. So comparing with the opposite side testis, I'm roughly saying it on inspection as a
I don't see that is that. This is a common problem, particularly if there is a testicular tumor or epididymo orchitis. You must say that on inspection, apparently there is no swelling or swelling, there is only an enlargement of scrotum. Exactly size is very difficult to match. You said there is a, right? You said skin over the swelling is normal with rugosity. Next slide. Next slide.
Yes, sir.
So why you are saying no ulcer over scrotum now?
Sir, if I'm able to see any ulcers, either
you are already said that there is no
skin
is normal. So it should be a routine. You should include everything in one. Skin is normal includes everything.
Yes, sir.
So why specific? Even on history you have asked. Any specific reason for asking or seeing about ulcer?
No, sir. Just
No. It cannot be just like that. Any reason why you are giving so importance to ulcer over scrotum?
no, sir. If ulcer is present over the scrotum, if with the testicular enlargement, either it can be invasion of the direct malignancy spread to the scrotum will change the stage.
Second point.
And also,
okay, got it.
Also,
but the point is that there was no ulcer is included. When skin is normal, that means there is no need to say anything further. What do you mean by left hemiscrotum is normal?
Sir, I couldn't see any enlargement when compared to the right side there. Right side, sir.
Okay. So you have said right side scrotal rugosity is separate than left side, right? That way?
Yes, sir.
But the scrotum is normal, right? Yes, on inspection, it is not possible to see the testis and epididymis on inspection. So most of the time, what you see is a scrotum only.
Okay.
You understand?
Yes, sir.
Right? If it is a hydrocele, there can be a difference in size. Otherwise, it is very difficult to see the much of a difference between these two. Okay, go to palpation. Right, just that figure. That can you say it is 7 centimeter? It's very difficult to see.
Yes,
so that's the practical part. I'm not saying you're wrong, but it's very difficult on inspection to say. Next.
Can I intervene here, sir?
Please, sir. Most fair.
Actually, I totally agree with you that to delineate a testicular swelling of a particular size on inspection is very difficult.
Very difficult.
But if you try to see the median raphe, then you can always say that right side testicular hemiscrotum is larger than the left one.
Opposite.
This much only can be said.
That much, yes.
So he hasn't described much about the median raphe, which is very important when describing this swelling part.
Okay, you have written very well that testicular sensation is not examined. Can you examine anything else? I don't know whether you, but this is a point of debate, but I would like that my teacher usually used to say, have you try to palpate the heaviness of testis? Okay, have you compared the weight of both sides? This has been well documented. If it is a inflammatory condition, weight of the testis will not be different. But if it is a malignancy, testis will feel heavier. It's a debatable. I am not saying that you should, but that should be just for your knowledge. If somebody asks, it's definitely.
It has to be done. He has to see the difference in weight of the two testes.
Yes,
has to be done.
That's what I believe.
No, it has to be done.
It has to be done. That is the more important because sensation you cannot say. I agree. But heaviness is very well documented. You must see both side testes that it is definitely heavier. And in the previous era, I don't know, but that was the single most important examination point we decide whether it is a malignancy or not. Please continue.
What are the things you looked in the cord structure? You said bilateral cord structure is normal. What are the things you specifically?
Yes, sir. Sir, the vas difference, sir. If the vas is thickened, it may point towards epididymoarchitis, sir.
So
which is
can a cord structure be thickened in the case of carcinoma of testis?
Sir, cord structure, the cremastic muscle hypertrophy will be there, sir, in a carcinoma testis. It is due to the enlargement of swelling and the cremastic overactivity, sir. So there will be enlargement of the cremastic muscle, sir.
Actually, sorry for intervention. In testicular tumor, as has already been pointed out, these testes are heavy.
Yes, sir.
So the spermatic cord becomes hypertrophied.
Yes, sir.
And there are two signs which are to be seen in vas difference.
Yes,
One
sir.
is
Sign of the vas
is beating of vas difference. beating.
Yes, sir. That
Right? If it is
corresponds.
repeated, that is also almost sure of
Yes, sir.
carcinoma.
Yes, sir.
Suppose the tumor is extending to the cord.
Yes,
So
sir.
how do you look in the cord, and what is the importance of that, assessing that?
Sir, sir, tumor continuing into the cord is stage 3, sir. In continuity, it will come as T3,
Stage
sir.
3 or T3?
T3, sir. T3, sir. In continuity, it is T3, sir. But without continuity, if there is nodularity or if there it means it's considered as metastasis, sir.
That will be put as M then.
M.
Naveen, you've done with your examination?
Yes.
Sir, yes, sir.
I think summary, total summary.
Have you
and
mentioned
diagnosis?
Have you
Sir,
mentioned?
no, sir. Sir,
Naveen?
diagnosis, I would like to give.
Sorry, he's asking something, Naveen.
Naveen,
Sir, yes, sir.
have you looked for gynecomastia?
Sir, I forgot to mention, sir.
Why is it important?
Sir, gynecomastia will be present in 5% of the cases of testicular tumors, and Sertoli cell tumor there will be gynecomastia, sir.
So if there are tumors which are functioning, they can produce. So
Yes,
this
sir.
is important, and you can't
Yes,
miss
sir.
it.
Yes, sir. Yes, sir.
Also, have you looked for the lower limb swelling, edema of
Sir?
the lower limb, swelling of the lower limbs?
Sir, no pedal edema, sir. No.
No. I mean, that is you're doing a general examination.
Yes, sir.
But in testicular tumor, is it important, and why?
Yes, sir. Lymph node, the paracaval, paraaortic lymph nodes, if they get enlarged, they may cause compression of the venous drainage. Caval obstruction, it will lead to pedal edema.
So IVC obstruction or can be compromised. So that is important. So you just can't just say that there's no pedal edema and walk away.
Okay, sir.
Right? You have to understand that here the swelling of lower limb has a different connotation than general pedal edema.
Okay, sir.
Right?
Yes, sir.
You have mentioned that there is no palpable inguinal nodes.
Yes, sir.
Everybody has palpable inguinal nodes. What do you mean by
Sir,
saying no palpable inguinal nodes?
Sir, inguinal lymph nodes, barefoot walking also it can be there, sir. But
see, my point is to differentiate between normally if you palpate 100 patients, you will palpate inguinal nodes always. But what is the difference between a inguinal node of this type and the inguinal node palpability in carcinoma testis or testicular tumor?
Sir, if inguinal node is palpable, means there will be scrotal skin involvement, sir, because CA testis will
not necessarily. Skin involvement is not always necessary.
Sir, retrograde spread from the paraaortic nodes.
When the inguinal nodes are involved in testicular tumor, when the inguinal nodes are involved in testicular tumor, until the scrotal skin is involved, the inguinal nodes are not involved.
Yes, sir.
Am I right that part?
Yes, sir.
So that is why even FNAC is not recommended.
Not done transcrotally, sir. Yes, sir.
Yeah, it's not recommended because the scrotal skin may be involved. So instead of writing no palpable inguinal abdominal and left supraclavicular lymph node is okay.
Yes, sir.
But once you write no palpable inguinal nodes, you say no significant inguinal lymphadenopathy. Once we say significant inguinal lymphadenopathy, it means what we are meaning it.
Okay, sir.
Yeah, Naveen, you said why did you palpate the abdomen for lymph nodes?
Sir, lymph node enlargement, paraaortic nodes can be palpable, sir.
Okay, they're the first lymph nodes to be enlarged. That's
yes, sir.
Okay, where would you feel these lymph nodes? In which part of the abdomen?
Sir, epigastrium, sir.
Right.
Oh, it's too high.
Sir?
Most common in epigastric.
Yes, sir, epigastrium, sir.
Okay.
I think we should go to now give the diagnosis after summary.
Sir, summary. Sir, a 40-year-old gentleman came with complaints of swelling in the right side of the scrotum for the past 6 months. No history of pain and no history of fever. No other comorbidities and no history of previous surgeries. On an examination, 7 cross 5 centimeter, hard, non-fluctuant, non-transluminant, swelling confined to the scrotal region with no palpable abdominal and left supraclavicular lymph nodes, sir. Actually, I've given a diagnosis here as a case of testicular neoplasm, sir, but I would like to give a differential diagnosis, sir.
I'll go back to the previous slide. Any reason for fecal staining 1+, which
No,
you
sir.
have mentioned?
No, sir. It's
Because-
on normal digital rectal examination, fecal staining is present, sir. Significance is that no mass is palpable, sir. If any internal iliac nodes is palpable, I can be able to feel that in for rectal
If
examination.
internal iliac lymph nodes are palpable, fecal staining can be present, you mean to say?
No, sir. That's a normal.
What is the, once you are mentioning that fecal staining is present. Okay. Sorry, I'm sorry.
So Naveen, my advice again, you know that what is my advice is say PR is normal.
No,
Okay,
but
sir.
that's very simple. Actually.
So
Okay, sir.
do not fall in a trap. That's
Okay,
it.
sir.
Okay, please diagnosis.
Naveen, sir has asked you to look for a gynecomastia.
Yes, sir.
And why do you want to look for gynecomastia and what hormone?
Sir, beta HCG, sir.
So with the beta HCG increase, any other system you want to examine other than gynecomastia?
Beta HCG.
So always remember beta HCG and TSH as almost all
TSH.
the same units.
Yes, sir.
So the same effect it can produce on the thyroid, and patient can have a hyperthyroidism with the effect of the beta HCG.
Yes, sir.
So that should be also happened because it's very rarely you can get gynecomastia, but there are cases reported with that. You have the hyperthyroidism also been reported with that.
Yes, sir. Sir, a differential diagnosis. First, I would like to give a benign cause of tuberculous orchitis, sir.
No,
considering
see,
this case-
I'll stop it. Sorry, sir.
No, sir.
I'll stop. Differential diagnosis doesn't mean you include all the possibilities.
No, sir. Only two, sir. Tuberculous orchitis or malignant. I can give a case of.
But if you say
The sensitive
tuberculous
organ-
orchitis itself, that we will be saying that it is wrong because the last organ in the body to be affected by tuberculosis is the testis.
Yes. Yes, sir.
You can say epidermoorchitis, that is different. Because starting,
okay, sir.
never ever
Okay.
say the word tuberculous orchitis as a
Okay, sir.
Chronic
At all?
Chronic
Yeah.
orchitis or
Sorry,
Yes. That is a chronic epididymoarchitis, yes. But
Yes, sir.
tuberculosis, most unlikely. It is
Okay, sir.
previously it was a different thing, and usually they used to present with sinus. Remember,
Yes, sir.
that is very
Yes, sir.
typical. We used to teach
Posterior, sir.
anterior sinus and posterior sinus.
Yes, sir.
It's okay. Now it's gone. But remember, chronic epididymoarchitis
Chronic
do
epididymis.
occur, right?
Yes, sir.
And usually, as the patient become older, that is commoner,
Yes, sir.
right? What is significance
Yes, sir.
of 40 years of age in your diagnosis?
Sir, age group, the group of testicular neoplasm that affects based on age group, sir. 20 to 30 years, you can think of a teratoma, sir. More 30 to 40 years, you can 35 to 45 years, you can think of a seminoma, sir.
Okay. Another question I wanted to ask, was there a presence of hydrocele?
No, sir. Uniformly hard in consistency, sir. No,
That is fine. But apart
Yes,
from
sir.
that,
no, sir.
in a
Secondary.
tunica, is it
Sir, no.
likely or not?
Secondary hydrocele can be present, sir.
So have you looked for it or not?
Sir, I've looked. No, sir. No secondary hydrocele, sir. Yes.
Okay. So what is the normal amount of fluid present in tunica vagina in any person? Just for my interest, because in this patient we will not be doing fluctuation. Have you tried transillumination?
Sir, transmission is negative, sir. In a small swelling, I will
What is
not
the
be able
cause
to.
of secondary hydrocele in this patient?
Sir, in case of secondary hydrocele,
You have already answered it. Which system is involved usually in testicular tumor? Lymphatics.
lymphatics is
So back pressure does so. Secondary hydrocele do occur. Yes, in chronic epididymoarchitis, you also find because of the local inflammation. But in testicular tumor, it does occur, though it is very minimal and sometimes difficult to identify.
Will
Okay.
you differentiate primary hydrocele from secondary hydrocele?
Sir, primary hydrocele, the testis will not be palpable separately, sir. In secondary hydrocele, the testis will be palpable separately.
Sorry to interrupt, Naveen. This is a
Yes,
misconception. Sorry, Naveen, let me hear. Let
Yes,
me
sir.
tell you something. There is
Yes, sir.
no rule that in primary hydrocele testis is not palpable. This is wrong concept everybody has developed. Primary hydrocele patient present late. By the time they present, the hydrocele is big, so testis is not palpable. But that doesn't prove that and in secondary hydrocele usually cause is such that patient will present early, epididymoarchitis. So their hydrocele is minimum, so you can palpate the testis. Understand this point. It is a wrong concept that primary hydrocele testis is not palpable, secondary early primary hydrocele testis will be palpable. It is a for the amount of fluid, it has nothing to do with the disease. Understand this point. Please continue.
One is the duration of the size of the hydrocele
Yes,
itself. Second
that
is
is important.
the testis itself. In a primary hydrocele, the testis is a normal size. So there is a less. But here in the secondary hydrocele, you will have some pathology. It's a consistency will be hard. The difference, the phase difference you have is more. So you will be easily palpable.
Yes, sir.
Let's say it is not a thumb rule, but it is only, but we can see that differentiation.
I'll ask a question unrelated to the present case. Naveen,
Yes, sir.
suppose a patient has epididymal cyst or large epididymal cyst or
Yes, sir.
spermatocele. How are you going to differentiate spermatocele, large spermatocele from hydrocele? Both will be transluminant.
Yes, sir. But spermatocele will not be clearly transluminant, sir.
Let it
It
be
does
like
not contains a clear.
Both epidermal cysts will be very brilliantly transluminant. How will you differentiate hydrocele from epidermal cyst?
Sir, epididymal cyst is mostly transluminant, sir. But from the epidermis, it will
very brilliantly transluminant.
brilliant transluminant, sir.
You can say Chinese lantern pattern, but that is very difficult.
Yes, sir. Due to septation.
Is it in position with the testis? Where it will be?
Yes. Sir, it will be in the posterior aspect, sir. The epidermal cyst will be in the posterior aspect.
Both
Sir. Posterior and
spermatocele
below.
and epidermal cyst will be.
Large scrotum, you can't say
Can't
it's
differentiate,
anterior,
sir.
posterior, lateral, right?
Sir. Small size you can differentiate, sir, but large.
Yeah. In
What is 3 syringe
spermatocele,
test?
sir.
Naveen, what is
Sir?
3 syringe test?
3 syringe test, sir.
Yeah.
Sir, I don't know, sir.
Okay, so no, it was before the era of again. Because what is the color of fluid in spermatocele? What is color of fluid in hydrocele? And what is color of fluid in epididymal cyst?
Sir, in spermatocele, it is barley water like, sir.
Very good. Yes.
Hydrocele, it is yellow, sir. Like,
Amber.
Sorry,
Word is
amber.
yellow
Yes,
amber. Yes.
Sir.
And epididymal cyst?
Sir, epidermal cyst.
It is brilliantly transluminant. So it should be.
White.
It can't
Not
be.
white, watery.
It is
Clear
clear.
water.
Watery, clear water.
Clear.
So that is what it is also described in the books. If you aspirate, you can decide what it is. Not done, but this is what just. Please continue.
Sir,
Okay, your diagnosis is T2, N0, M0. What do you mean by T2?
sir, actually, in staging of testis, the T1, T2 is a pathological staging, sir. Where T1 is involved testicular
It's
tumor.
pathological. Why you put it here?
No.
You can still. I'm not. I'm asking you a question. Defend
Clinically,
yourself.
clinically, I
say
cannot
what is
differentiate. So clinically, I cannot differentiate whether tunica albuginea is involved or not involved, sir. So, but cord is not involved, sir. So, putting as T2, sir.
And also whether it's what is it is it less than 3 centimeters or more than 3 centimeters?
Sir, more than 3 centimeters, sir. Sir, cross 5. But
Right. That's
T1.
T1B. Some people
T1,
say
yes, sir.
T1B.
Yes.
Okay, so the size is important. That is more than 3 centimeters, and the cord is not involved clinically.
Yes, sir. Yes, sir.
Right. So then it falls into T2. So 2 things: more than 3 centimeters and cord not involved.
Yes.
You can still say clinically that's T2, though it is a pathological diagnosis. Still, you can make it T2 as clinical because of this two conditions.
Yes, sir.
Right. So please carry
Please carry on. So now, what will you
Diagnosis.
Hmm.
Working diagnosis.
Accept your diagnosis? Now, how will you go further from here?
Sir, as an extension of the clinical investigations, I would like to go for ultrasound of the scrotum and abdomen, sir. I will look for the echogenicity of the testis and the swelling, sir. And in case bilateral testis also, in early stages, we can pick up any calcifications is there in the opposite side testis or not, sir. In abdominal ultrasound, we can look for.
So you will do an ultrasound of the scrotum and ultrasound of the abdomen.
Yes, sir.
Okay.
Yes,
Now
sir.
I give you the ultrasound report of the scrotum.
Yes, sir.
The right testis is showing hypoecosity.
Yes, sir.
Left testis is normal.
Okay, sir.
Abdomen you find normal. No lymph nodes are found. No nodes are visible in ultrasound.
Sir, two possibilities, sir. The hypoechogenicity without abdominal lymph nodes, either it can be due to the isoechogenicity of the node to the ultrasound, sir. So CT abdomen, I'll do, sir, next CT abdomen. Then I will subject the patient for serum markers, sir. Tumor markers.
No. See what CT is going to tell you in addition to what.
No, sir. If there are lymph nodes that
no,
be
I
able
am
to
giving you
pick
the
up in
ultrasound report. It said that right testis is hypoechoic.
Yes, sir.
Left testis is normal. No lymph nodes in the abdomen, lower abdomen or upper abdomen.
Yes,
With
sir.
this report of ultrasound, go ahead.
Sir, next I will do serum biomarkers of beta HCG, AFP, and LDH, sir.
So you will not advise CT scan?
Yes, sir. CT abdomen I will do, sir.
No, I mean, don't say if I have asked. Will you do
No,
a
sir,
CT or not? If yes,
Yes,
why?
sir.
If not, why?
Sir, I will do a CT, sir.
Why?
Sir, sometimes isoechogenic nodes in the abdominal nodes cannot be picked up by ultrasound, sir. So I look for a CT, sir. I will ask for a CT.
Not only isoechoic, even the paracaval nodes, it is not that
Yes,
easy to pick up by ultrasound. And even
Yes.
retroduodenal nodes can be present. That can be also not. So it is mandatorily, it is better you go for a CT scan also.
Yes.
So CT is a mandatory part of your workup, right?
Yes.
Whatever the ultrasound says, CT is a must.
Okay, sir.
Okay. Okay.
Do you do X-ray chest or not?
Sir, yes, sir. X-ray chest also I will do, sir.
So
Choriocarcinoma.
why? What are the things
blood
you
bone.
can see in X-ray chest?
Sir, secondaries can be all seen, sir. Otherwise, even after parietic nodes get involved, the tumor can spread via the crural, diaphragmatic crural lymphatics to the posterior mediastinum also, sir. So posterior mediastinum widening can also be seen.
Yes. Don't give reason. You can see what is cannonball metastasis.
Sir, secondaries in the lung cannonball.
In which condition you will find it?
Breast malignancy, sir. In beta
Not in
HCG.
testicular?
Beta HCG, sir, in the choriocarcinoma of the test.
Okay.
Okay.
Would you do CT? Sorry, sir, please.
Naveen, in ultrasound,
Yes, sir.
okay, in this age patient, what do you
Yes,
think
sir.
is the most common type of testicular tumor?
Sir, seminoma, sir.
Can it be can it be teratomas also?
Sir, teratoma can.
Okay,
Yes.
can. Now, can you by ultrasound distinguish between the two?
Sir, mature teratoma with cartilaginous or bony can be seen, sir.
It is answer is yes, and then you
Yes.
discard.
Right.
Then you can see.
Right. And what would a seminoma? What's the typical picture, ultrasound picture of a seminoma?
Sir, hypoechogenic.
Is homogeneous or heterogeneous?
Simple. What you see on cut section, the same is seen on ultrasound also.
The very simple thing you can remember, solid is seminoma.
Yes, sir.
So it is
That is the-
homogeneously you can get a.
Yeah, please.
In a clinical case, and what are the conditions you will suspect seminoma, and when you will suspect teratoma?
Sir, with the age, younger age group 20 to 30, teratoma, sir. 35 to 45, look for a
Somebody-
seminoma.
somebody can-
Seminomas can be bilateral presentation also, sir.
If somebody comes at the age of 60, 70, what kind of carcinoma you will expect?
Sir, lymphomas also can.
Lymphoma, we are asking the question is seminoma and teratoma. So seminoma has a bimodal age group. You have at the third decade and also at the late age.
Yes, sir.
In situ trophoblastic seminoma, which we are getting at the late age. And
Yes, sir.
second, most important is a undescended testis. If the patient
Undescended.
has an undescended testis will always go for a seminoma. It will not be a teratoma. So in this
Yes, sir.
condition, then it can be bilateral. The bilateral tumors can be either lymphoma and seminoma, but more
Seminoma.
cancers, seminoma. So how we are
Okay,
going
sir.
to proceed?
What tumor markers will you look for? Will you get one?
Sir, I will look for beta HCG, serum LDH, and alpha fetoprotein, sir. First, suspecting malignancy, I will go for architectomy, sir. High inguinal architectomy.
No, hang on.
No.
You can't just go for treatment straight away. Okay.
You will do ultrasound, you will do CT scan, then you will do tumor markers. Okay?
Yes, sir.
And then only these high HIU will be done. Attempted. Tumor markers, you told that beta HCG, LDH, and
LDH and alpha fetoprotein, sir.
alpha.
For the staging purpose, which tumor marker you will take?
Sir, all three, sir.
No, all three. Because you said before doing a surgery, you are going to do the tumor marker.
Yes,
So
sir.
will that be taken as a
No, sir. 1 week after architectomy, I will repeat
for the
the.
staging purpose and seeing that it is only after architectomy and after giving a 1 week time because the half-life period is over. So that tumor marker only counted for the staging purpose.
Yes, sir.
But pre-operatively, you must do a tumor marker to see that. Anything which doctor can give a clue. Suppose you have an alpha fetoprotein, you are thinking clinically as an seminoma, but
Yes,
your
sir.
alpha fetoprotein is high. What will you think?
Sir, non-seminomatous, sir. But and in late stage also it can get elevate, sir. But non-seminomatous means alpha
Clinically,
fetoprotein.
even if you are thinking it's seminoma, even your histology if sometimes put. But if the alpha fetoprotein is high, we need to put it as a non-seminomatous way. So because modality of treatment is also different. So tumor marker is important for these two purposes, to deciding on the modality of treatment and also to put in the staging also.
Yes, sir.
What is that LDH?
Sir, lactate dehydrogenase,
What is that? What is it of action purpose?
sir, converting pyruvate to lactate, sir.
So what other carcinomas you think in other malignancy you think of LDH? You will measure LDH. Melanomas.
Melanoma.
When you take the division, it comes to the staging purpose, that is LDH is also considered in melanoma.
Yes, sir.
Okay, Naveen.
Yes, sir.
So just said that we'd get this tumor markers to distinct to find out whether it's a seminomatous or a non-seminomatous, or a germ cell or non-germ cell tumor, isn't
Yes,
it?
sir. Yes, sir.
So what is the difference basically between a seminomatous and a non-seminomatous germ cell tumor? Any difference between the two?
Sir, the cell of origin. Be different, sir.
Go ahead.
Sir, in seminomas, the cell of origin is the germ cells. Non-seminomatous.
And the term is saying germ cell and non-germ cell, right? But what are the difference clinically? What is
seminiferous tubules?
Sir.
Teratoma from?
Teratoma from the totipotent cells.
Where?
Sir,
Okay, it is a retate testis.
retatious.
So what are other change? Other sir is asking other differences between seminoma and teratoma. You already said the age. You have said.
Yes, sir. Age group, sir.
which has a better prognosis?
Sir, seminoma, sir.
Okay, so that's one. What does anything else now? How do they spread? Any differences in metastasis?
Yes, sir. Lymphatic spread more common in seminoma, sir.
And it is hematogenous in the
Hematogen.
tonsil. Right. And anything to do with treatment?
Sir, seminomas are sensitive to radiotherapy, sir.
Right. And this is radio-resistant.
Right.
Right. And of course, seminomatous are much larger, and the testicular shape is maintained. While in non-seminomatous, the shape gets distorted.
Sir.
Teratoma can be mature, immature.
Immature, sir. Mature teratoma is considered as benign.
If there is any importance on the treatment modality or the malignancy, I mean, with the way we treat. Suppose it's benign teratoma you have, one is a
mature teratoma is considered as a benign, sir. Architectomy will be sufficient. Immature teratoma.
The treatment do not differentiate whether it's a mature or immature teratoma. Any teratoma is taken as together. It's a non-seminomatous tumor, so all are putting as the same and treated. In the non-seminomatous group, only choriocarcinoma is important because choriocarcinoma we will not think of what is
Bleomycin will not be done. Bleomycin will not be given already. Lung metastasis will be common and pulmonary fibrosis and RP-LND.
RP-LND will not because they will not produce that kind of things.
Yes.
Go ahead. How will you proceed?
Sir, high inguinal architectomy, sir. And high inguinal architectomy is sent for biopsy. Then, based on pathological staging, T-staging, I'll stage the tumor, sir.
How high? What do you mean by high architectomy?
Sir, high architectomy is by a transinguinal incision. The testis will be pulled up and a soft clamp will be applied, sir. Then at the level of the deep ring, we'll double ligate the cord and then for HP, sir.
Something wrong in your description. You said, will you pull testis first or will you apply clamp first?
Clamp first, sir. Clamp.
So don't pull the testis. Why so?
Sir, while manipulating, will tumor emboli can occur, sir. So.
Fine. Okay. So how will you proceed once you get the report? I think sir has already discussed most of the point.
Yes, sir.
Do you have any option to not to do architectomy?
Sir, we can do, if frozen section is available intraoperatively, we can do a frozen section, sir. Chavasus maneuver. We can open the testis along the anterior convexity and we can, if it is negative, means you don't need to. Turns out to be malignant, we can continue. Sir.
Okay, suppose when patient comes to you, already the scrotum skin is involved. How will you proceed then?
Sir, scrotal skin is involved. T4 is also, you can go with hemiscrotectomy also, sir. Hemiscrotectomy and with architectomy. And if the tumor turns out to be seminoma, then we'll give a radiotherapy, sir. Following radiotherapy, follow up CT scan, and based on the residual nodal mass, we can go for RP-LND or not, sir.
Okay. Agreed. Fine. I think okay.
So how many stages are there in the testicular?
Sir, 3 stages, sir. No stage 4, sir. Stage 1, stage 2, stage 3.
Suppose the patient has a T4, N0, what is the stage?
Sir, T4, N0, sir? M0, sir?
N0.
Sir, it will T4, N0, M0 will come under stage 1B only, sir. T2 to T4, N0.
The carcinoma where the T4 lesion is also taken as a stage only.
Yes, sir.
It has only 3 stages.
Yes.
Which carcinoma, you know, which has only 2 stages?
2 stages. Melanoma, sir.
No. There is only 2 stages. Stage 1. Even M1 will come under the stage 2 only. This is another case which we are going to discuss today.
Carcinoma thyroid.
Papillary carcinoma thyroid, less than 55 years age group.
Less than 55
years. 2 stages. Which carcinoma has 5 stages?
5 stages.
So Wilms tumor or nephroblastoma,
Wilms
when you have a bilateral, it will be considered in the stage 5.
Stage 5. Yes, sir.
So you have done an orchidectomy, you have done then is it only the surgery is your treatment, or you have any other option you have?
Sir, chemotherapy and radiotherapy, sir. Radiosensitive tumors for seminoma, we'll go proceed with radiotherapy, sir. Non-seminomatous chemotherapy, sir. And RPLND, sir.
Now, what is the guidelines of NCCN guidelines for seminoma? Is it radiotherapy is the first preferred?
Sir, for stage 1A, we can give radiotherapy, sir. But 2 cycles of BEP regimen can also be tried, sir, with RPLND, sir.
So now the concept is more towards chemotherapy, not the radiotherapy. So radiotherapy has its own side effects, and you need to have a bilateral protections and other things.
Shielding of
So
opposite
the first
sexes, sir.
thing is only in a stage 2B, when you have a node which is very high lesion, not responsible, there you can try for some radiotherapy. But otherwise, even for seminoma, though we know it is a radiotherapy is highly sensitive, but NCCN guidelines recommends only the chemotherapy. So first, after the surgery, orchidectomy first, followed by the chemotherapy. So what is the chemotherapy you will use?
Sir, BEP regimen, sir. Bleomycin, etoposide, and cisplatin, sir.
Suppose, as you said, that the lung is involved, where you are not supposed to use bleomycin, then?
Ifosfamide and dacarbazine can be used, sir.
So, if we can. So you initially said about the Saman banking.
Yes, sir.
What is the importance of that?
Sir, bilateral undescended testis. Sir, if he's unmarried or married and no kids, semen banking is of importance, sir. In future, if he wants to have a children, it can be used.
So suppose we now talking about always reconserving breast conservation like things, and suppose the patient says even after removing the testis, will you able to do the reconstruct that?
Sir, synthetic material like silicone balls are available, sir. So it can be used for reconstruction, sir.
What is the prognosis of your patient?
Sir, good prognosis, sir. In stage 2, also up to 90% prognosis is good, sir. Stage 3 up to 75%, sir.
So how will you assess the prognosis?
Prognosis by serial CT and serum marker, sir. CT scan initially for every month for the first 6 months, sir, followed by 3 monthly for the next 1 year.
What are the criteria to assess this one? What are the International Gem Cell Consortium? What are the criteria to say this patient will do well and this patient will not do well?
3 risk groups, sir. The good, intermediate, and poor risk.
What are that? What are they?
Sir, for seminoma and non-seminomatous results, sir. For seminoma, only good and intermediate, sir. No poor risk. In seminoma,
there is no advanced group or the
no poor
risk group.
Yes. Yes. In good group, serum markers and all will be low, sir. Their serum markers will be high with pulmonary metastasis, sir. In non-seminomatous good group, S1, all serum markers with S1 will come under that, sir, without pulmonary metastasis. Intermediate will be S2, sir, that the serum biomarkers in the group of S2 with metastasis, regional nodal metastasis and pulmonary nodal metastasis, sir. Non-regional lymph node and non-pulmonary metastasis will come under poor group, sir.
So when you do salvage RPLND?
Salvage RPLND.
What is N3 tumor?
Sir, N3 more than 5 centimeters, sir. After giving a chemo or radiotherapy, if the remnant is more than 3 centimeters, we can go for salvage.
Salvage RPLND. You are not doing it first, but after giving a chemotherapy, if there is tumor is shrinking, then you can go for a salvage therapy.
Salvage. Yes, sir.
What RPLND you will use?
Sir, bilateral RPLND, sir, but the risk of retrograde ejaculation is there, sir. Modified RPLND, the inferior limit of dissection is only up to the origin of the inferior epigastric, sir. On the side of malignancy, we can extend up to bifurcation of the aorta into common index, sir.
So which nerve is responsible for producing retrograde ejaculation? Which system?
Sorry, sir, L1, sir. Sympathetic. Bilateral L1, one side L1 should be sparred.
So what is the role of parasympathetic?
Sir, parasympathetic is excited. It is only.
No, what is the role? Ejaculation.
Erection, sir. Erection by parasympathetic, sir. Ejaculation by sympathetic.
So here, it's most possibly you will injure the sympathetic system, so patient can have a retrograde ejaculation for that.
Okay, sir.
So I think we'll go to the next case, sir. Kanavel, sir. Real busy, Kanavel, sir.
Ajay Khanna, sir, your closing comments.
Sir, please go ahead.
I think we can go for the next case.
Yes, sir. Yes, sir. Kavya is ready. He has already shared. Kana Naveen, you should unshare the screen.
Yes, sir. Thank you, sir.
No, you have anything other than this seminoma, teratoma? You have Naveen? Are you here?
Sir, yes, sir, I'm there, sir.
What is the Sertoli cell and Leydig cell tumors?
Sir, Sertoli cell and Leydig cell tumors are non-germ cell stromal cell tumors, sir. Leydig cell is masculinizing tumor, sir, and Sertoli cell is a feminizing tumor, sir. In case of Leydig cells, the masculinizing features will be there, sir. Even after architectomy, it cannot be reversed, sir. In Sertoli cells, feminizing will be more.
Why it is not reversed?
Sir, because the opposite side testes would have already gone for hypertrophy, sir, in masculinizing tumors.
Pankaj Modi, sir, you would like to ask any closing comments, sir? Closing questions?
No, it's okay. That the problem with most of the students we have seen is that they have prepared theory like anything. If you ask them chemotherapy agent, this, that, they know in detail. But I think they are not giving enough importance to clinical examination and history part. Naveen, you did very well as far as the question answer of the treatment is concerned. But I think you should work more on a clinical examination and description. Yes, otherwise, he was good. Fine. Thank you.
Thank you, sir. Thank you.
Thank you, Naveen. You please stay back. Do you have any questions, Naveen, to clarify from the national faculty?
Sir, no, sir.
Thank you very much.
Thank you, sir. Thank you.
So, good luck to you. Kavya, can you please switch on your video, start your presentation?
Yes, sir.
Go to the first slide, Kana.
Yes, sir. Yes, sir.
Srinivasan, sir.
Yes, sir.
Kavya, please introduce yourself, unit chief, and start your presentation.
Yes, sir. Good evening, sir. I am Dr. Kavya, currently doing my final year post-graduation in MS General Surgery in Coimbatore Medical College. My HOD is Dr. Lakshmi Narayani Madam, and my chief, Dr. Ravi sir, and my guide, Dr. Srinivasan sir, and my assistant professors are Dr. Radhika ma'am and Karthikeyan sir. I would like to present a case of thyroid swelling. Coming to chief complaints, a 53-year-old female patient, Mrs. X, hailing from Kunyamuthur, Coimbatore, who is a homemaker by occupation, came to our OPD with chief complaints of swelling in front of the neck for 12 years. History of presenting illness. Patient was apparently normal 12 years back when she noticed a swelling in front of her neck, initially small in size on the right side of her neck, which gradually increased to present size, almost 5 to 6 times the initial size, almost occupying the entire neck now, and there is no increase in size since 5 years and not associated with pain. No history of difficulty in breathing, difficulty in swallowing, or no history of hoarseness of voice. No history of features suggestive of hypo or hyperthyroidism. No history of cough with hemoptysis, jaundice, headache, seizures, or bony pain or swelling. No history of swelling elsewhere in the body. Coming to past history, she's a known hypertensive since 3 years on tablet amlodipine and not a known case of diabetes, diabetic bronchial asthma, tuberculosis, epilepsy, and coronary artery disease. No history of irradiation to the neck. She is not taking any medications. No history of previous surgeries or drug allergies. Coming to personal history, patient takes mixed diet. She takes iodized salt. No history of excessive intake of brassica family vegetables. Her appetite is normal. Bowel and bladder habits are regular. She's a non-smoker and non-alcoholic. Menstrual and obstetric history. Age of menarche is 13 years. Normal 28-day cycle. Flow lasting 4 to 5 days. Attained menopause 5 years ago. Obstetric history. Para 1 living one. First childbirth at 20 years of age. Single daughter by normal vaginal delivery. No history of similar complaints in her family. So summary of history, a middle-aged woman with complaints of swelling in front of the neck for 3 months, which swelling in front of the neck for 12 years, which progressively increased in size for 7 years and remained static in size since 5 years, with no pressure symptoms or symptoms suggestive of hypo and hyperthyroidism and malignancy. Sir, shall I proceed with examination?
Wait.
Anna, wait.
Wait. Go to the first slide.
Yes, sir.
Okay. So you said patient is hailing from this particular area. What is significance of that?
Sir, if it's a hillshed area, iodine, the water which patient takes will be poor in iodine, so more chances of endemic goiter, sir.
So where it is on the hill or foothill?
It's a foothill, sir.
So why it is less in iodine in a foothills?
Water will wash away all the minerals.
Okay. So do you know any endemic areas?
Foothills of, sir, Coimbatore foothills, sir, because it's down of Ooty.
So what is the definition of endemic goiter?
It is more commonly present in the particular geographical regions.
We can't use the word more and less. There must be
Less.
specificity.
Okay, sir. Sorry, sir.
It is permanently present there.
Okay, sir.
Okay. So which type of goiter is this? Is it endemic?
Yes, sir.
This, no, your patient.
Yes, sir.
The endemic goiter.
I think so, sir. Not so sure.
Not sure. So if it is not endemic, which type of goiter it is? What do you call it by definition? Sporadic goiter. What do you call it?
Sporadic goiter, sir.
Sporadic goiter.
Right?
Right?
You say it in the hill area you get, but we are getting a lot of cases from the seashore.
Yes, sir.
What is the reason? Seashore also will produce an endemic goiter. There is a,
Yes. So why this patient has developed goiter? Because because of iodine deficiency, or can it be something else? Because it is since 12 years, so malignancy is most unlikely.
Yes, sir.
So what is the other cause of a sporadic goiter other than iodine deficiency?
Autoimmune disorder, sir.
Autoimmune is not common. Any other which is usually described?
TSH fluctuation.
What is dyshormonogenesis?
Absence of enzymes related to thyroid hormone synthesis, sir.
Okay, if it is due to iodine deficiency, which type of goiter is known? What will be the thyroid shape and everything?
It's globular shape, sir.
Globular. What is globular shape?
no.
Iodine deficiency we are talking of.
Okay, sir.
Okay, if the patient develops goiter due to iodine deficiency, what do you call it?
Endemic goiter.
No. Iodine deficiency in one family and particular person. Okay, let me ask another way. Will it be a nodular or will it be a diffuse?
Diffuse goiter, sir.
What do you call that early stage of diffuse goiter due to iodine deficiency? Diffuse hyperplastic goiter.
Diffuse hyperplastic goiter. Okay,
Diffuse
sir.
hyperplastic goiter. So what is difference between diffuse hyperplastic goiter and physiological goiter? You know what is physiological goiter?
Yes, sir. In pregnancy and
Very
puberty.
good. Excellent. So that itself is the answer. So what is the answer?
In pregnancy and puberty, there will be increased demand for
Yeah, so it is a relative deficiency. It is not
Yes, sir.
complete deficiency.
Yes, sir.
Okay. So is it reversible? Diffuse hyperplastic goiter is reversible or not?
Yes, sir.
It is a reversible.
It is reversible, sir.
So suppose the patient comes to you, what treatment you will give? I am giving a diagnosis, patient is having diffuse hyperplastic goiter due to iodine deficiency. What treatment you will give?
We'll supplement iodines.
Then patient's goiter will increase. Let me tell you. Okay. It should be thyroxine.
Thyroxine.
Altroxine.
You should not
Next. Next slide. Okay. So what you have written is front of the neck. What do you mean by it?
Anterior aspect of necks.
So it is only on anterior aspect.
Anterolateral
on
aspect.
inspection. So always make it happen. So there are so many things are used: anterior and lateral, thyroid area, lower part of the front and lateral part of the neck. It is not only front of the neck,
Okay,
right?
sir.
Predominantly on right side,
Yes, sir.
right? Okay.
Yes, sir.
So why it has stopped increasing now? You said it is stopped since 5-6 years.
Yes.
Previously it was increasing. Now it is not. Why it is not increasing? Any particular reason you must be knowing that has stopped increasing or any as such? Anyway, either way, what is significance of that? It has stopped increasing in size.
It's not progressing, sir. Means no malignant changes in that.
Anything else? So is it a diffuse goiter or nodular? What do you think it is?
It's a nodular goiter, sir.
Nodular goiter. Okay. Next, you said it is not associated with pain.
Yes, sir.
So why you have taken the difficulty in breathing as the first part? First
Sir,
important
since it's
mistake.
a huge goiter, pressure symptoms can be there, sir. So I
Okay.
asked the history of
Uh-huh.
difficulty in breathing.
So what will be the difficulty called as? How the patient will come?
Striders.
Stridor. So why the such patient is likely to develop stridor? That is emergency. Goiter is since 12 years.
If there is any hemorrhage into that,
Very good. Sudden increase in
size,
which will lead to stridor. So
Yes.
how will you define stridor?
acute respiratory distress, sir, due to
No.
airway obstruction.
No, no. Stridor. How will you describe? How will you know that yes, this is stridor? It is airway obstruction. I agree with you, but why it is known as a stridor? It's a with noise, obstruction with noise. Very simple words. I'm not in very
Yes,
fancy. The
Yes,
patient will have a typical difficulty with noise.
Yes, sir.
Is it common to have a difficulty in swallowing? You have taken it first. That's why I'm asking. I would not take it first.
No, sir. It's not so.
It is, suppose patient gives history of difficulty in swallowing. What does it mean usually?
Pressure over the esophagus, sir. If it's a malignant growth, it
No.
infiltrates.
Remember, that's why the word should be difficulty in swallowing is very common. It can happen with sight. Patient is aware. It's a dysphagia word is very important. It is all difficulty in swallowing is relative term. You should use word if there is a dysphagia, which usually suggests malignancy. Whatever may be the size of thyroid, benign thyroid will not cause
dysphagia.
esophageal obstruction.
Yes.
How the benign thyroid will cause the airway obstruction? Because of size only?
No, sir. If, even in benign case, if there is any hemorrhage into the nodule,
Forget about hemorrhage. Which type of thyroid will develop airway obstruction? Usually it is bilateral. Unilateral rarely causes that.
Yes.
Remember that. Unless
Yes.
it is malignancy, that itself is again a different topic.
yes, sir.
So how will it cause airway obstruction? You ask that. Fine. Difficulty in breathing. Which type of thyroid is likely to cause that?
Isthmus, if it's involved.
No. It's a usually large thyroid over the period of years, which are usually known as a colloid goiter. How
Okay,
do they cause airway obstruction?
Tracheomalacia.
Tracheomalacia. What is that?
Weakness of tracheal wall because of chronic pressure over the trachea by
So
thyroid.
is it due to pressure?
Right.
So pressure comes first or something else comes first? What do you mean by tracheomalacia? It is not obstruction or pressure. What is
Collapse.
malacia means?
Collapse.
What is
No,
Malaysia?
collapse is different. Osteomalacia you must be knowing. What is that?
The word tracheomalacia means what?
No,
Weakness of the tracheal.
weakness is not that. I am giving you a hint. Understand the hint.
Go
Osteomalacia.
for weakness. But the bone, if you say something more. What is the difference between scaphoid trachea and tracheomalacia? Both are same or not?
Different, sir.
Wow. See, tracheomalacia, there is definitely demineralization is there. The cartilage goes for that. Scaphoid is only because pushing from one side, lateral to medial. Here it is tracheomalacia. It's a different.
So because of the long-standing increased vascularity local area, washing off of the calcium occurs from the tracheal ring. So tracheal ring becomes softer. That is known as a tracheomalacia. Then comes the second stage, which is known as a scabbard trachea. What is that? Nowadays, this is theory. We don't see such cases now because of the advancement, but they do come. Now, nowadays, the common cause of stridor is malignancy and not the benign disease. That also.
Yes.
So after demineralization, ring
comes with the difficulty in breathing with the thyroid swelling, goiter. What do you think is a first possibility?
Sir, I didn't get the question. Sorry, sir.
Patient comes to you with a goiter and gives the history of difficulty in breathing.
Okay, sir.
Will you think it's an obstruction as the first cause or anything else? So commonest cause is only secondary thyrotoxicosis. When the patient has secondary thyrotoxicosis, long-standing goiter, he will come with a more of difficulty in respiration than a patient with a large swelling comes to, unless it is an anaplastic carcinoma, even more carcinoma will not come with that difficulty much.
Yes. Okay. So that is the point. You should understand. So what I wanted to say, when you see the swelling like this, that hyper should be ahead of difficulty in breathing and swallowing. Because the first thing I will be worried is whether patient is hyperthyroid or not.
Okay, sir.
Right? So what are the important symptoms or you have asked, questions you have asked to rule out hyperthyroidism?
I had asked about insomnia, irritability, tremors, and palpitations.
Most common.
Increased
Palpitation is a one thing
loss.
Very important. Anything else?
Diarrhea, sir.
Diarrhea. Before that, there is a very typical describe. You should always remember. Somebody asks you symptoms and signs of hyperthyroidism is weight loss in spite of
adequate appetite.
Good appetite, weight loss. There is a classical feature of untreated hyperthyroidism.
Yes, sir.
Sweating is another very important sign. You should understand that. Sweating, moist palm, palpitation, right?
Yes, sir.
So you should know. You say no history features. So, but what are the features you have asked? This is very important. You should know the basic feature of hyperthyroidism.
Yes, sir.
But nowadays we always go for T3, T4 rather than test. So what is the clinical index is known as for our hyperthyroidism? You know that index 19 point plus 2, forget about it. Sorry, sir. It's known as a Vance index, which was very popular for a clinical examination. So at least you should know the basic symptoms which are causing the hyperthyroidism. You should know. So how did you know that patient doesn't have hyperthyroidism?
Depending on the symptoms which I asked, sir.
Okay. Next. So again, the same thing, hemoptysis, this and that is, I don't think is very good. Next.
So this, hello, Dr. Rajavilu here. I want to add only one thing.
Yes, sir.
Kavya, you said diarrhea.
Yes, sir.
Can you define diarrhea?
Increase in frequency and liquidity of stools, sir.
Do you think the hyperthyroid patients get such symptoms?
Yes, sir. Diarrhea is one of the symptoms in
No. Why do you get diarrhea in hyperthyroidism?
Increased gut motility, sir. So,
okay. If you actually ask them, they pass normal stools, but the frequency is increased.
Okay, sir.
It is not actually a diarrhea. It is only hyperdefecation. Maybe it's a misnomer.
Okay, sir.
Okay.
Okay, sir.
What kind of tremor you get?
Sir?
You asked for tremor, no?
Yes, sir.
What do you mean by that, and what kind of tremor you get? You are expecting in the hyperthyroid?
Fine tremors, sir.
Hmm?
Fine tremors, tongue fasciculations.
Can you define fine tremor? Is it a physiological or pathological?
It's physiological, sir.
So it is exaggerated physiological,
Yes, sir.
low frequency, high frequency, low amplitude.
Yes, sir.
And it is usually demonstrated rather than patient may not give you the, because it is so fine. And
Yes.
usually how the why there is a tremor, fine tremor is the reason.
Sir, increased increased activity in neuromuscular junction, sir, due to.
Activity or fatigability.
Sir?
How will you demonstrate the tremor? That will give you the idea.
We'll ask the patient to stretch his hands forward, sir, upper limbs forward. And
Why
we'll
you
ask,
need to stretch hands? What is the basic problem in hyperthyroidism? It's increased sympathetic activity, part 1. And
Yes.
part 2 is because the direct effect of thyroid antibody, which causes certain symptoms. So, how does the increased sympathetic activity causes the fine tremor in finger and tongue? So it's a rather, if the patient is having a resting hand, he or she will not have a tremor demonstrable. Usually then you have to stretch. Why do you stretch the fingers? And why you keep it palm down and not palm up? The reason is here we want to see the small muscles of the finger, that is the lumbricals and interossei are supplied by a sympathetic or autonomic system. In a presence of hyperthyroidism, they go easy fatigability. So as soon as you stretch it, in normal circumstances, tremor should not appear. But in a presence of increased sympathetic activity, they become fatigued easily. Same thing in levator palpable superiorus. That's why easy fatigability of upper eyelid. That's why you would sometimes need a paper to demonstrate the fine tremor. So usually patient will not complain of tremor.
Yes, sir.
Please, sir. Next. Again, I would suggest, go to the one back. This, I would not suggest you should mention this.
Okay,
no
sir.
history of excessive intake of Brassica family. I don't, this is not, this is too much of information. What is Brassica family? Just for what can happen?
Just cabbage and cassava and cauliflower.
What is Kale? Kale. What is Rape? Rape. Those are all this. What is that? So my real advice is don't fall in that. That's right. I understand why you have said that, but it is not needed actually. Too much of information.
How the cabbage cause your hyperthyroidism?
It's a goitrogen, sir.
How? Sir is asking. Actually, not cabbage never causes it. Actually, it is cabbage family. How does it cause? Now, this is what you are opening the can of worm. This can happen. So don't mention those things. It's like an anchovy sauce pus.
So normally when we are eating cabbage or Brassica family with the cooking, so when you cook and all this thiocyanate will be get washed away. It will not be there. Only when you are using as a salads, which is there in the Western diet.
Yes.
So you get, like soya beans also.
Yes.
So that also we are not taking a raw. We are taking only
so we are not usually exposed to that. How does it causes the goiter? Sir has given you hint. Said some chemical. You know that? How does it cause it? How does it cause the goiter? So this chemical in a row mimic like iodine and they compete with iodine. So instead of iodine, it is taken up, giving rise to artificial iodine deficiency.
Okay, sir.
So that is the basic.
Peroxidase enzyme is also because of thiocyanates.
And that is the which is used in medicine also.
Same thing for the coastal belt also. Now, because calcium oxalate, that will be competitively inhibit with iodine. So iodine, though the seafood has a rich iodine, but it is coming in, it will take the calcium oxalate will be taken and not the iodine. So that is a relative deficiency and you are having the endemic goiters in the coastal belt also.
please. Okay, sir. Anything you'd like to ask? Okay, continue with the examination, I think, sir.
Yes, yes, please.
Okay.
Coming to general physical examination, after getting consent in a well-lit room with adequate exposure, examination is carried out. Middle-aged female patient who is moderately built and nourished. She is conscious, oriented, afebrile, and her hydration is fair. Her height is 158 centimeters and weight 58 kg with BMI 23.2. Her pulse rate is 88 beats per minute, measured in right radial artery, regular in rhythm, good volume, no specific character. Her blood pressure is 120 by 80 millimeters of mercury, measured in right arm in supine position. Her respiratory rate is 18 cycles per minute. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema, and no eye signs were present. Coming to local examination, inspection, a single swelling of size 12 into 10 centimeters in front of the neck, in front and sides of the neck, moving with deglutition, extending about almost at the level of hyoid bone to 1 centimeter above suprasternal notch, laterally extending till posterior border of right sternocleidomastoid muscle, and on left side ending 1.5 centimeter medial to anterior border of sternocleidomastoid with well-defined margins, irregular surface, lower border of the swelling is seen, few dilated veins present over the swelling, no scars seen and no visible pulsations. This is the swelling. Palpation. In sitting position with neck slightly flexed, patient examined from the back and from the front. No local rise of temperature, non-tender. A single swelling of size 13 into 10 centimeters in front of the neck with moving with deglutition, extending from almost at the level of hyoid bone to 1 centimeter above suprasternal notch and laterally till posterior border of a right sternocleidomastoid and laterally till 1.5 centimeter medial to anterior border of sternocleidomastoid. Well-defined margins, nodular surface, variable in consistency, lower border of the swelling was felt, skin over the swelling, dilated veins present, no pulsations or thrill. Bilateral carotid pulses felt, right side pulse deviated more laterally, trachea could not be palpated, no cervical lymphadenopathy. In auscultation, no bruit was heard. Systemic examination, cardiovascular system, S1, S2 were heard, no murmurs heard. Respiratory system, bilateral, normal vesicular breath sounds heard, no added sounds. Parabdomen soft, non-tender, and no organomegaly. Central nervous system, no tremors, tongue fasciculations, proximal myopathy or reflexes. Reflexes were normal. Spine and cranium was normal. So summary, a middle-aged woman with complaints of swelling in front and sides of the neck for 12 years, which progressively increased in size for 7 years and remained static in size since 5 years with no pressure symptoms or symptoms suggestive of hypo or hyperthyroidism and malignancy. On examination, 13 into 10 centimeter swelling present in front and side of the neck, moving with deglutition, with nodular surface, well-defined margins, dilated veins over it with variable consistency, with right carotid pulsation displaced more laterally and no lymphadenopathy. So diagnosis, multinodular goiter in euthyroid status.
You have seen only one nodule, one swelling. No?
Yes, sir.
So, sir.
Let us go back to inspection.
Okay, sir.
The inspection, kindly note repeatedly we are saying don't just say inspection, local inspection. Say that what you are going to inspect. Examination and inspection of the head and neck region or the neck.
Okay, okay sir.
And Pankaj sir has already said in front. It is better to use that anatomical language. You have thyroid region. There's a swelling in the thyroid region. If you say that will be more easily understand than saying front, back, enemy. All that thing is not necessary in anatomical.
Okay, sir. Okay, sir.
Okay. So what do you see from this, your inspection? What is your impression?
Sir, it's
in both you have said only single nodule, as sir was pointing out.
No, sir, I was telling a swelling with nodules over it, sir. It was a single swelling as such. 13 into 12 into 10 swelling.
I don't. In palpation?
Yes, sir.
Okay, go to palpation. Let us go to palpation. So where are nodules?
Sir, nodular surface.
No, do not confuse it with it. So what I want to say, when you say multinodular goiter, what does it mean? I think Rajavelu sir is asking the same question. I think so.
Yes,
sir. Thyroid gland is enlarged, sir, with the multiple nodules over it. So I tried to say was it was a thyroid swelling with nodular surface, sir. Multinodules. Multiple nodules.
You'll actually feel lot of grooves in between. One.
It's a bossulated or nodular?
Oscillated, sir.
Okay. Another question. Is the one lobe of thyroid is enlarged or both lobe are enlarged?
Both, sir.
Both lobe are enlarged.
Yes,
Okay.
sir.
So what about the left lobe? Where have you mentioned that? I would like to know that.
I mentioned everything as a single swelling, sir. Right and left.
What is the shape of the swelling?
Hemispherical, sir.
So what is the normal shape?
Butterfly shape, sir. Sorry, sir.
Huh? Remember, in thyroid, this is very important point.
Okay, sir.
Butterfly has 2 lobes or 3 lobes?
2 lobes and isthmus, sir. Pyramidal lobe can be present, sir.
Okay. Generally, when you have an obvious pyramidal lobe, then you have. In which goiter you have more pyramidal lobe? Nowadays, in Hashimoto's, the nodular goiter which is having that pyramidal lobe will be also involved in that.
Okay.
So the point here is that in thyroid, there is a distinct things. One is a whole thyroid is enlarged, right? So right lobe and isthmus. It can be unequally enlarged. Some may be large, some may be little smaller, but all. So it will give typical bilobe appearance or butterfly swelling, what we call it, right?
Okay.
Second is it can be diffusely enlarged or it can be whole thyroid with multiple nodules. But lobe architecture is there. There may be nodule in each lobe, right? Or it can be only one lobe enlarged, right? With single nodule that you call solitary thyroid nodule.
Okay.
You understand? So
Yes,
what
sir.
is it in this case? The size of nodule may be variable and gives the impression like that. So here, what is it? Can you palpate anything in the left lobe?
Yes, sir. Left lobe was enlarged, sir. Both right and left lobes were enlarged, sir. With the nodules, I could palpate nodules over that, sir.
It will be a vertically oval shape swelling, much more in the picture which you have shown.
Yes.
It's shown
I'm
like-
not convinced actually. What you are saying is, I'm not convinced. And where you have written that left side thyroid is enlarged, I would like to know that. Where have you written it?
I have not written, sir.
How come that? And it looks like it's only right lobe and isthmus is involved. So how will you know that left lobe is involved or not? Have you seen the sonography picture? I think sonographers must have written that. That's
Yes,
why
sir.
you are saying left lobe is enlarged. So don't confuse your clinical judgment with the sonography. Sonography is useless as far as the clinical part is. Clinically, you cannot convince me that left lobe is enlarged.
Okay, sir.
Sonography may be differ. That's why we go for investigation.
Okay,
But
sir.
we should mention clinically. So
Okay.
clinically, is it a solitary thyroid nodule or part of multinodular goiter? Clinically, I am talking. So how the whole
I asked you to put the other side. Sir, I saw the case, sir. It was a
Yes, sir.
diffuse enlargement. Both lobes were involved. It was a
Yes.
huge goiter, sir. Let's say
Yes.
that's what I said. You post the anterior, left, right lateral, and post left lateral picture so that you can know how far the extent is there. It's a huge goiter, sir.
Yes, sir.
You
And I
wouldn't-
would again say that because when you are going on online platform, a short video with movement with deglutition will exactly define both lobe are enlarged or not. One thing is very clear. If the lobe is enlarged, you should be able to demonstrate. Then clinically, it is both lobe enlarged.
But when she is saying laterally in the left side, it even 1.5 centimeter medial to the sternocleidomastoid.
Yes.
If there's a left lobe, if it is enlarged, it will definitely go up to the sternocleidomastoid.
Exactly. That's what I was going to ask. If the left lobe is there, where it will be?
Exactly. Can I also intervene? And
Yes,
even
sir.
you mentioned in palpation also, it is almost at the level of thyroid bone. You have to be very specific when you talk about palpation. And next is can you go to the inspection slide?
Slide. Yes.
Yeah. And you have said it goes till the posterior border of the right sternocleidomastoid.
Yes.
And what did you confirm in the palpation?
It was swelling was extending till posterior border, sir, of sternocleidomastoid, right sternocleidomastoid.
What is the covering actually of the thyroid?
It goes anterior or posterior? Posterior to sternocleidomastoid, it reaches to the posterior border, or it goes anteriorly and reaches the posterior border?
It goes posteriorly, sir.
It
So
actually
in sir is asking, what did you write in palpation? Go to palpation.
Please avoid this word like almost all. These all adjectives should not be there in a scientific way.
Okay.
Right? Only what you feel.
Okay, sir.
I told you it's going anteriorly and going up to the posterior, but it's coming anterior to sternum, almost, sir, like that.
It is actually it is only the deep fascia which is engulfing the sternocleidomastoid as well as the thyroid.
Yes.
You will actually see the thyroid goes behind the sternocleidomastoid. It will actually push actually.
Yes,
Okay.
sir.
It cannot go in the.
Kavya, can I ask you one question?
Yes, sir.
How will you know the relation of sternocleidomastoid with thyroid lobe in palpation? Well, how will you demonstrate in exam? I may ask you, if I become examiner, show me the relation between sternocleidomastoid and the right side thyroid nodule. How will you demonstrate it?
Sir, I'll ask the patient to sit. By standing standing behind the patient, we'll slightly flex the neck forward.
If you stand if you stand behind the patient, you cannot demonstrate. This test is always done from front, never from back.
Lahis method.
No. Very simple. I am asked. Remember, universal principle. How will you see the relation of muscle with the swelling?
We'll contract the muscles.
So how will you contract? Have you done it?
By asking the patient to.
Have you done in this case? That's what I would like to know. Does swelling increase, become more prominent or less prominent? Have you tried it?
If you said it goes posterior to sternocleidomastoid, the size should reduce.
Yes. Always thyroid swelling become less prominent because by rule, sternocleidomastoid is also covered by investing layer and it covers the thyroid. And thyroid is behind it, so it will grow always behind the sternocleidomastoid. It never comes anterior to sternocleidomastoid.
Yes, sir.
So when you contract the muscle, the swelling will decrease in size. You can appreciate it is going behind the sternocleidomastoid.
Okay, sir.
So have you done the same thing on left side? So you can judge whether there is a swelling on left side which is decreasing or not. Understand? That is a very important point. Give enough importance to sternocleidomastoid relation with the thyroid swelling. It is an important point. Similarly, you are just saying the one point, I think in inspection it was there, which is a very important thing. Yes, in palpation, you have said lower border of swelling is seen and lower border of swelling is felt. What is the importance of that?
If the lower border is not felt, retrosternal extension should be suspected, sir.
Yes, so it should be very clearly mentioned separately.
Yes, sir.
Getting below the swelling, which sometimes it is known at, right?
Yes, sir. Yes,
so
sir.
normally, how do you examine thyroid? From front or from behind?
From behind, sir. And then from.
Sir is asking about palpation.
Palpation.
From front, sir.
Inspection is always from front, obviously. Sorry, sir. But palpation.
From behind will.
There are certain things you have to do from front and certain things from behind.
From behind, yes, sir.
Sir is asking the question.
Yes. So inspection is predominantly from front. Palpation is from behind.
Yes, sir.
Why? Front and behind both, but behind. Why from behind also? Any reason for that?
We will be able to feel the posterior superior aspect of bilateral lobes, sir.
You can feel everything, but why from behind? How does it help?
It will stabilize the thyroid. Prevertebral fascia.
So what will be the position of neck?
Slightly flexed, sir.
Why it is slightly flexed?
Is it always you are going to keep it flexed?
No, sir. Extension also we can.
The advantage of being behind is you can put your thumb on the back occiput and you can make it instead of asking the patient to put that. You can make the flexion and extension and
Yes,
simultaneously you can do that. Both
It is the
positions you have to examine.
The way in which you can examine will be comfortable for you. The curvature of the hand, fingers.
Yes. And it will be comfortable for patient. To examine, to palpate from front is little difficult. One more reason is it is examined in slightly flexion position, patient become comfortable, and there is a relaxation of investing layer as well as the strap muscle. That will help you to palpate the surface better. Even getting below the swelling is easily examined from behind. So predominantly inspection from front and palpation from back. But yes, you have to do both, but that is the predominant. The reason is this, right? Then will you do a Pizzello's position, which is very popular with student, but not popular with consultant. What
Sir,
is that?
if a patient is short-necked and obese, we can ask the patient to put his or her hands behind over the occiput and slightly extend the neck so that the swelling will become more prominent.
Yes, that's what the sir was saying. Position can be changed. So sometimes extension is better, sometimes flexion is better.
Yes, sir.
But remember, movement with deglutition, relation with sternocleidomastoid, and getting below the swelling, these three are, because these three are most important point in palpation. You should remember, as far as the thyroid swelling is concerned, and lobes. One lobe, both lobe, isthmus, pyramidal, all this.
Yes,
right?
sir.
Okay, we'll go with your that. Why there is a movement?
One more question, sir.
Please,
Can
sir.
I intervene?
Please. Yes, yes.
Madam, where did you palpate the carotids?
Sir, by drawing a horizontal line from hyoid bone till anterior border of sternocleidomastoid, sir. At the point where it hits the junction, I palpated, sir.
In the hyoid bone level?
Yes, sir.
What after you palpated?
But swelling was present till the hyoid bone, sir. So
You palpated which carotid?
right side and left side, sir.
No, which carotid?
Oh, which carotid?
There are two carotid neck.
Common carotid, sir.
Common carotid will not come to your hyoid.
Where exactly you're supposed to palpate and how do you
At the upper
palpate?
border of thyroid cartilage.
And you
Agreed.
palpated.
That is the one landmark. Sir is asking exactly where will you palpate?
Approximate middle of sternocleidomastoid, sir.
No. So it is described. The problem with is we are giving too much importance to management and not the examination. That is a problem. At the level of upper border of thyroid cartilage, at the junction of upper 1/3 and lower 2/3 of sternocleidomastoid against the C6 transverse process, which is also known as a carotid tubercle. So why this much meticulous description?
Why against C6 transverse process?
Transverse process. Huh.
Why?
Why? Yes, sir is asked. Oh, sorry, sir.
You know, what are the important anatomical landmarks at the C6 level?
Bifurcation of common carotid into external carotid.
Bifurcate above. That is, it's not bifurcate at that level. It bifurcate much above. That is why we are feeling the common carotid at that level.
Okay.
Anything else? Any other anatomical structure? Where the trachea begins?
Listen to class means you have told.
Where the esophagus starts?
Sternal T2.
No, all this is important. C6 level, respond to the cricoid cartilage level. That is above that to the common carotid bifurcate. Then the pharynx becomes
Pharyngoesophageal junction.
trachea. That is a very important landmark which you are going to see.
Yes.
Actually, you will feel it very comfortably, common carotids, and also any pulsation you have to feel against a bone. And the transverse process of C6 is the longest.
Okay,
so that is the reason why we are able to feel it.
And
But I
that's
have
why
a question here. I have a question in this case.
Yes.
You said it is actually going and pushing the sternocleidomastoid, going up to the posterior border.
Yes, sir.
And in this case, how did you make out the carotids?
Sir, pulsation was.
Did you actually felt it? And one last slide, you have mentioned it is pushed laterally. And how did you confirm that?
Sir, pulsation was present almost at the posterior border of sternocleidomastoid, sir.
How did you palpate? It is very difficult in this. You have to, very difficult to push.
Okay. So the point here is that what sir wants to say is that it is very important to know what is the normal site of palpation.
Okay.
Then it can be two things. One is you can palpate at normal site, or
Okay,
you
sir.
can palpate quite laterally, or you may not able to palpate.
Okay, sir.
So what is significance of that?
If we are not able to palpate, then carotid sheath involvement might be present in malignancy. So very sign positive, sir.
Yes. And in this case, where did you palpate? That was the sir's question, actually.
Sir, I felt it along the posterior border of sternocleidomastoid, sir. Like middle 1/3.
I think Pankaj sir made it very clear. You need not always say that it is palpable. If you are not able to feel it, please say it is, I'm not able to feel it. That is quite right.
Sometimes
And
it becomes very difficult, or it can be quite lateral.
Not necessarily it should be a malignant one. Even a huge goiter, it can engulf, but still may not feel the carotids.
And it can cover it. It can cover it.
In the Berry-Sen, is a flow is stopped or the only pulse is not felt?
Pulse is not felt, sir.
Why?
Carotid sheath will be infiltrated, so
Now you have felt the carotid over the carotid. There was a thyroid. Over there was a sternocleidomastoid. Still, you are able to feel that. Then, do you think that carotid pulsation will be stopped with the carotid sheath involvement? So it will take long time. So we will not go into the details of
it. Will not. It's beyond the scope of that. But remember, you must know the normal site of palpation, which is very, very important. Same way, you said moving with deglutition. What do you mean by that? Here you will be able to read. I know that.
Yes, sir.
So what do you mean by when you say moving with deglutition? What is the meaning of that?
The patient to swallow, that swelling moves during deglutition, sir.
So why this swelling or whatever swelling you are saying is thyroid moves with deglutition?
Sir, thyroid is enclosed by the pretracheal fascia, sir. Pretracheal fascia is in turn attached to cricoid ligament and the larynx. So when we swallow, cricoid ligament and larynx will move, which along with thyroid moves during deglutition, sir.
Which other structure move with deglutition?
My goit covers and posterolaterally condenses and forms a ligament. That ligament goes and gets attached to the cricoid cartilage. Not just simply covering. The posterolateral aspect, it gets condenses and forms a ligament.
Yes,
That
sir.
is why it's called the suspensory ligament.
Or
So
Barry's
how much ever
ligament.
the thyroid gets enlarged. See, this is a huge thyroid. It could have come down even into the chest cloth. Why it is not coming? Because of this suspensory ligament.
Okay, sir.
So it's attached to the cricoid cartilage. Now,
Yes,
next question Sir is asking. How
Sir,
does
my
cricoid
question is different. Thyroid moves because of Barry's ligament, but there are other structures which also moves with deglutition. What are those structures, or what are those swellings?
Larynx, sir.
Larynx itself, agreed.
Trachea.
Obviously, then.
Larynx and trachea same.
Yes.
So do you understand? So do not understand. The point is that structure which are covered by pretracheal fascia will all move with the deglutition. Understand? Thyroid is incidentally one of them. There is a pretracheal lymph node, prelaryngeal lymph node, or the laryngeal swellings. They also move with deglutition. Right? One more typical feature of pretracheal fascia which allow it to move with deglutition, which is that feature. And how it is different from investing layer and prevertebral fascia. There are three fascias in neck.
Yes, sir.
So investing layer is fixed all around, upper, lower. Prevertebral is also fixed. Pretracheal fascia is unique fascia which lower end hangs free like apron and which allow the movement with deglutition.
Okay, sir.
Right? It goes into thorax up to arch of aorta, but it hangs free. It is not attached lower down. It does not get. So that's why it gives free movement with deglutition. So any structure which are there along with the larynx will move with deglutition.
Okay, sir.
Right?
Yes, sir.
So what is difference with movement with deglutition and movement with protrusion of tongue?
Movement with thyroglossals.
The difference. What is difference? Understand, I will give you that. All swelling which moves with protrusion of tongue will move with movement with deglutition. But reverse is not true. Why? Only thyroglossal cyst moves with protrusion of tongue. Why?
Because it's attached to foramen cecum, sir. Embryologically.
Then after adult patient.
Communication between hyoid bone till which.
What is that? What do you call it? It is attached by
thyroglossal tract.
Tract. The word which is important is thyroglossal tract. That's why it moves with protrusion of tongue.
Yes.
But it will also move with deglutition. Understand this point.
Yes.
Okay, please. Because you have, just go back. What sir was trying to tell you this. You have written, you were able to palpate it, right? It is deviated laterally. You have said trachea could not be palpated. Where did you palpate the trachea?
Sir, in the suprasternal notch, sir.
So it is not palpable.
No, sir. I could not palpate, sir.
Then there is it is known as a retrosternal extension.
You are able to feel the lower border, no? Lower border of the gland, you are able to feel.
Yes, sir.
There must be something in between that suprasternal notch and the lower border.
So when you say trachea cannot be palpated at the suprasternal notch, means there is a retrosternal extension.
Okay, sir.
Do you understand? So what you write down is very important. Trachea is almost always palpable. But more important here is, which you have not written, I wanted to discuss. More important. It's a very obvious, deviated word.
You said that thyroid is deviated to the left. It goes up to the posterior border. Is it not?
So where is trachea? Is it in midline?
It deviated, sir. It must be deviated.
So you
must be now.
Trail sign must be there. Insinuation will be there.
The point is that how will you know that it is deviated? Are there any clinical tests to judge that whether it is deviated or not?
Yes, sir. 3-finger test, sir. We'll put.
So for the trachea should be palpable.
Yes, sir.
But here trachea is not palpable.
Not at that point. Some other point.
Some other
Right.
point. Yes.
In front of the neck. Go little above.
What is inspection? What is palpation? What is auscultation? All the three you can use to see the thyroid, trachea.
Trial signs.
Trail sign. On the inspector, you can see that.
What is trail sign?
That's if sternocleidomastoid one side is prominent, that side trachea will be deviated.
Right. Other tests, sir, is in palpation.
Palpation, 3 fingers will do, sir. Ring finger and middle index finger. We'll put in both ends of medial ends of clavicle, and with middle finger will feel for the deviation, sir.
If you don't feel the trachea there, you'll feel a very hollow space there. That is another evidence.
Yes.
Next thing is, did you look for the thyroid notch?
Yes, sir.
What is the direction? Is it anteriorly facing the notch?
So thyroid, goiter was present, sir. So
No,
I couldn't.
Adam,
No,
sir.
no, that's not.
There, you are not able to see.
No, sir.
But one thing you should not forget, just a hint, in such a large unequal swelling, trachea is almost always deviated. Understand that point.
Yes, sir.
You can also auscultate, as sir has said, and you can approximate it. Why it is important to know whether trachea is deviated or not?
Mediastinal shift.
What is treatment in this patient? Probably.
Total thyroidectomy, sir.
So how will you do it? You need to give anesthesia or not?
So,
Yes. Intubation. Difficult intubation.
Second point is that this will also give you the idea whether only one lobe of thyroid is enlarged or both lobe is enlarged. When both lobe are equally enlarged, deviation is minimum or not present. Usually, extreme deviation suggests unilateral enlargement.
So in this case, you would have definitely expected you to write something on auscultation. Don't go and see for, we have already seen that it's not a thyrotoxicosis case. And you
So
are not,
Bruit is not important.
we are not interested in Bruit. Go ahead and see for the breath sound, what is there. And
okay. So what is your diagnosis? Now we go to diagnosis. I think time is. Kavya,
Nodular goiter, sir.
go to that. Put your diagnosis. Okay.
Yes, sir.
Multinodular euthyroid goiter. Right? So we have a controversy now. So how will you confirm that whether you are right or we are right?
I would like to do a thyroid function test, sir.
There is no controversy in euthyroid state.
Before that,
Ultrasound.
anatomically.
Ultrasound. Have you got ultrasound report?
What ultrasound you will use, no?
Yes, sir.
Any specification for ultrasound, or you will just write an ultrasound?
Ultrasound.
What is the frequency of the probe you will use?
You should catch hold of the examiner's question. Where is asking what time? So next is, no, again he gave you another hint. What frequency you will use?
Will you use a high frequency or low frequency?
What will be the shape of the probe?
Yes. Why sir is not pulling here? It's a very important. Nowadays, ultrasonography is a gold standard. Most of our decisions are taken on that in thyroid. So it is very, very important. Don't take it lightly. Even malignancy, there is so much detail. Because we are going to ask you what is thyroid grade, because it's also important. What is the ultrasonographically finding which are suggestive of benign and what are suggestive of malignancy? How you take ultrasono guided FNAC. So it's a very, very important. Which probe you are using, how much frequency you are supposed to know that, because actually basically depends upon the two main three: ultrasonography, thyroid function test, and FNAC. That sums up most of the thyroid investigation. There are so many others, but these three are main. You are supposed to know all detail of these three. Please. Okay, so ultrasonography is done. It shows only right lobe and isthmus is enlarged, left lobe is normal. Now, what will you do?
We'll go for tissue diagnosis, we'll go for FNACs.
Okay. Tissue diagnosis, you will go for FNAC. Why will you go for FNAC? Why you want FNAC? Patient is having swelling since 12 years.
FNAC gives you tissue diagnosis?
Cytological diagnosis.
You go for FNAC. Right? You do FNAC or your pathologist is doing FNAC?
Pathologist, sir.
So slowly, general surgeons are giving everything to others. And ultrasound and FNAC are all procedures.
FNAC is a bedside procedure.
You must learn to do that. Huh?
Yes, sir.
Yeah. Because just to give hint, there is no time, but you should know how FNAC is done. And nowadays, you should say always ultrasound guided in thyroid.
Yes, sir.
Right? Why
yes,
ultrasound guided? Yes, sir. Right. Why?
Because it will give more. We can get more representative samples, sir, if we do under image guidance.
Such a large swelling is there.
If we hit it in a wrong place,
no, not wrong place. You tell it correctly.
It is wrong place.
You're going in the answer correctly, but the end is not good.
End is not good. It's a very important. You are supposed to know all this. I am only asking the question which needs clarification. Don't worry. It is not that you are doing bad, but I am asking the question which needs, because those are controversial and can create a problem.
Okay.
You said nodular, isn't it? Sometimes you hit the, what happens is necrotic places. That is why ultrasound guided, the active nodule, the nodule which is there, or the normal tissue you have to take it from.
Okay.
You may hit the necrotic area when you do blindly.
Okay.
So you can take sampling from highly suspicious area in ultrasonography on which the thyroid. You know what is thyroid grade?
Yes, sir.
Yes, what is that? Tell me.
Thyroid imaging reporting and.
What is thyroid grade 1? What is thyroid grade 2? Thyroid grade 3, 4?
Thyroid grade 1 is which needs negative, sir. Additional investigations are needed.
In 1?
2 is benign.
What additional investigation needed in 1?
Negative, sir. I thought I confused with Birat's. Sorry, sir.
Okay, no issue, no issue.
1 is negative, 2 is benign, and 3 is probably benign, 4 is follicular, and 5 is suspicious of malignancies. 6 is proven malignancies.
What are the components in the thyroid?
Sir?
What are the components we look in the thyroid?
Exactly. Sir is asking on what basis you put a thyroid grade. I give you a hint. Size.
Whether it's a solid or cystic, size of the lesion, vascularity, the lymph nodes.
Lymph nodes. So how do you make out it's a lymph node? What is to say it is a malignant lymph node?
Loss of fatty film will be there, sir, and it will be more round in shape rather than oval shape.
Any echogenicity, any role?
Hypoechoic, most probably it will be malignant, sir. Hydroechoic will be probably benign, sir.
Anechoic?
Malignancy, sir.
Anechoic?
Cis fluid.
Taller than wider.
That is also very
Taller than wider. Yes, sir. Benign, sir. Taller than wider.
the capsule. Sometimes
Yes.
capsule is useful, right?
Yes, sir.
Sometimes
Yes.
where nodules are doubtful, you can take from most suspicious nodules. So that is the important point. Okay. So FNAC is probably benign in this case. You have done it, right?
Yes.
So
Yes,
now
sir.
what will you do?
Sir, since this is a huge goiter, I
Don't
would like
use word huge, goiter. Fine.
Okay, sir.
This is not very huge. Don't worry.
Okay, sir.
13 centimeter, agreed. It is a multinodular goiter. Size may be 2 centimeter, 5 centimeter, doesn't matter. Now what will you do?
CCT chest, sir.
Why? Why?
To look for a vessel increase display.
No, in a multinodular goiter, what do you want to go and look for?
You yourself have said there is no retrosternal extension.
Nothing, sir.
Great.
Yes, sir.
There is no retro. Lower border can be felt. Why
Yes.
you need CT? Ultrasonography doesn't show any lymph node. It is a multinodular thyroid, no extension anywhere. Pulsations are normal. Why do you want to do CT? An FNAC report is probably colloid goiter.
What are the indications for CT?
Yes, sir.
To look for retrosternal extension, sir. First one.
First.
And second one for exact anatomical orientation to relation with the carotid vessels of trachea.
So in all patients, you will need that.
No, sir. Only
It is not done for that. Never.
Yes.
So
Sir is asking.
So
CT.
when you have a central neck nodes, ultrasound may not be able to give you the exact picture. So if you are suspecting a central neck node, there you are also justified in doing that. Suppose the patient has some Horner's syndrome or patient has some difficulty, you can find out whether there is any mediastinal nodes or any problem. Or one of the inoperability thyroid case is when it is going to the extending to the T4B lesion going to the pterygoid space. Extension things, and that will be also important. So we will look into that. The bony
One more point is if the FNAC report is suspicious of papillary, it is must. CT is must in those cases. Follicular depends. It is a discussion, but if papillary, irrespective of size of tumor or the size of nodule, CT is must. Why?
in order to look for a central neck node, sir, we need to plan upon
all lymph node.
for all
Right?
lymph node.
All central is easier seen in CT than others. Ultrasonography may pick up other nodes, but central are missed. So if papillary is there because it's sprayed by lymphatics, that should
Yes.
be the answer.
Yes, sir.
Follicular doesn't spread by lymphatic.
By
If
lymphatic.
papillary, I would like to see all the lymph node possible. That is the important point. In this patient, I don't see any reason to do CT.
Okay, sir.
So what will you do now?
We will go ahead with the surgery, sir. Total thyroidectomy.
anything you missed, ma? You have now made diagnose. You said clinically euthyroid, and your anesthetic also want to give an anesthesia, or you do not want to confirm your status. Thyroid function test.
Thyroid function test.
It is to be done as a baseline. Even if patient is euthyroid, it is must for a post-op. Right?
Yes.
Okay. What is the role of doing PTH when you are planning total thyroidectomy?
To look for a parathyroid base level.
No, serum PTH pre-operatively. Is there any role or not? That also you learned that, sir, I don't know. Even in exam, that will help you.
I don't know, sir.
Yes, that's better.
That is the best answer.
Because it's very important. Because you will have very limited time, not a time like this. So more questions are, more you can answer. Otherwise, you will be just waiting. Okay, it is not mandatory. You understand? It is not mandatory.
Okay.
Should you check for serum calcium?
Calcium. That's the next question I was going to ask.
Yes, sir.
Why?
Preoperative calcium value, sir.
But why? Obviously, it is for preoperative.
Parathyroid, if parathyroid has been removed accidentally, post-operatively, we can compare with it. Baseline level, if we know the baseline calcium level of the patient.
Which calcium level? Which type of calcium level you will be interested in?
Ionized calcium, sir.
Ionized calcium. Always say serum ionized calcium is yes. To compare post-operatively, because Many a time level of PTH does not correspond with the level of ionized calcium. So it is that. So it has been said, which are the pre-operative mandatory investigation?
Routine, sir. CBC, complete blood count.
No, for thyroid. Forget about CBC.
Thyroid function test, sir.
One is thyroid function test.
Calcium.
Always calcium level, and indirect laryngoscopy, which will be converted into direct also before surgery. So as a surgeon, why it is necessary to do that?
In order to know the preoperative vocal cord status of the patient, sir.
So how will it help?
So that patient, if he has vocal cord palsy or something, for legal issues, it will be helpful. That
Forget about legal. Legal is fine. Any other reason? What is the percentage that there can be only already silent vocal cord parts? It should be in all thyroid cases for a rule out in silent vocal cord palsy, to rule out involvement if there is solitary nodule and possibilities there. You understand? It will help you to plan your surgery and you can explain to the patient, right? We'll not go in detail of that. It itself is a big topic. There is one more question very commonly asked. What is the role of thyroid scan?
Thyroid scan, it's helpful to identify toxic.
In this patient, will you do thyroid scan or not? In your patient, I am talking about.
No, sir.
Why not?
Sir, if I am suspecting any toxic nodule or toxic features, thyroid scan is actually helpful to.
Okay, this same patient has a increased level of T3, T4, which is controlled by antithyroid drug. Patient has a USG, so multinodular goiter. Agreed? So what is the role of thyroid scan in this patient?
In that scenario.
You understand my patient? Patient is hyperthyroid.
Okay, sir.
Okay means what?
If it's a toxic nodule or not.
Will you do scan or not?
No, sir is giving a scenario.
Yes, multinodular goiter, toxic multinodular goiter, treatment, it is going down. Now, will you do or not? One condition you will do.
The toxic adenoma.
You said what toxic nodule? Autonomic toxic.
Autonomic toxic nodules.
So the question here is that the previously we have been taught, just to clarify, I'm like hot nodule, cold nodule, warm nodule. That concept is gone. If ultrasonography shows that there are multiple nodules, irrespective of anything, surgery is only one, and that is total thyroidectomy. You understand? The scan is not going to change your management.
Yes, sir.
The indication is patient is toxic. Do you understand? And there is only one nodule. In that solitary toxic nodule is a scenario where it can be done.
Also helps you to differentiate transient hyperthyroidism from hyperthyroidism, actually, with the Graves' disease.
Okay.
Okay, sir. Sorry, I will have to leave now.
Yeah, now it's already 10:15. So what's the surgery?
Thank you very much, sir. Thank you very much.
Thank you, Pankaj sir. After a long time, we are meeting.
Sorry, I was very busy with my daughter, sir. She had gone to the second daughter also, so I was a little bit busy and I had a personal issues. But I'll be more, sir, I will be more regular now. Thank you very much.
Thank you very much.
Thank you, sir.
And give one of my resident the chance, sir. I will tell him to phone you, sir.
Good, sir. Welcome, sir.
Okay, thank you.
One of your resident is here. One of your resident is here, sir.
Ah, yes, but she is in plastic.
Yes, sir.
Yes, Nupur is there. Yes.
Yes, sir.
Okay, thank you.
Thank you, sir.
Have you have any questions?
Raju sir has come.
I'm fine. I just listen to it.
Kanagvel sir. I think he's busy.
I think Srinivasan sir, you can close that session because
Yes, sir. Yes, sir. Thank you, sir. Thank you, Rajvel sir, Raju sir.
Thank you, sir.
Yes, sir. Bodhi sir, Pradeep.
Nice to see Rajavel sir also back in action.
Yes.
I'm a Rajvel sir after a long time, sir.
Yes, sir. Srini, sir.
Yes,
Kavya, that was a good presentation.
Thank you, sir.
As Pankaj sir said, I think we have to give more importance to clinics also.
Okay, sir.
And you will not have so much time of discussion, ma, but you may be asked anything, but not everything.
Okay, sir.
So anything, the basic things like, or if don't talk about the fascia and why it moves, all these things, they will not go for the discussion at all.
Okay, sir.
That is what I said. It's a clinical examination.
Okay, sir.
Karnagaran sir, ஏதோ கேள்வி இருக்கா?
No, sir.
Silent அந்த கடைசில வந்தாரு.
Karnagaran.
Kanavil sir, please.
Rajvel sir, thank you. உங்க phone
Oh,
reach
thank you.
பண்ணவே இல்ல, நான் ட்ரை பண்ணிட்டே இருந்தேன். No problem. Very happy you could join.
Yes,
sir.
yes, sir. Thank you so much. Jayalal, Srinivasan, Karnagaran, எல்லாரையும் ரொம்ப நாள் ஆச்சு பார்த்து.
Sir, you can send your candidate, sir.
Yes, sir. Sure, sir.
Hello, ரொம்ப நாள் ஆச்சு வந்து. Please.
Badro, sir.
Karnagaran said since last time.
It is a very good platform.
Yes, sir.
All the postgraduates are enjoying this.
Yes. The
Thank you very
questions
much, sir.
also from national faculties.
Yes, sir.
Everything. Sir, okay, sir. Good night, sir. Thank you,
Thank you, sir.
Kavya.
Good
Well
night,
done.
sir.
Keep it up.
Thank you, sir. Thank you very much. Kavya and Naveen, very good job.
Yeah,
Thank you, sir.
well done to both of you.
Pankaj sir, we would wish you have frequently, sir.
He said he'll come, sir.
I think Sir has left. Sir has left.
Okay,
He said
okay.
he's
I will
busy.
catch up. I will
No,
catch
he's
up.
busy with this. He was busy with his daughter. So
Okay,
he will
okay.
come in. He will come join frequently.
Thank you, sir. Thank you.
Thank you, sir.
Sir,
Thank
can
you,
we
sir.
call
Good
it
night,
a
sir.
close, sir?
Yes, sir. Please,
Thanks,
sir.
sir.
Thank
Thank
you.
you.
Thank you. Thank you.